Assalamu alaikum and good afternoon to everyone joining in UK and Europe. So now we go to the SAHF DAR conference, which I and Mohammed have been involved in from its inception, and we have been hosting it. We used to have the live conference, the last one we had in the British Museum, so we are welcoming everybody to join it. The chair of the conference is going to be Vinod Patel. Mohammed, do you want to say a few words before we hand it over to Vinod?
No, it's just that it's sad not to be with each other face to face, but having said that, virtual is making it easy, and I can see that the number of attendance is really quite strong and healthy. So perhaps there is some benefit of the virtual, and the program it's quite strong. I look forward to the following sessions.
Thank you very much, Mohammed. So the next chair for the conference is Professor Vinod Patel, who's a professor of diabetes and clinical skills at University of Warwick. He is a board of trustee of South Asian Health Foundation and has been very actively involved both in research guidelines around diabetes and in Ramadan. So it gives me a great pleasure to welcome Professor Patel. Vinod, do you want to take over?
Thank you very much, Vaseem. I think you've had an amazing session over lunch in UK, at least, on the guidelines group. And we now move on to the formal part of our proceedings, which is the SAHF and DAR conference. We have 4 excellent speakers coming up, and we also have an embedded symposium as well. Once again, I'm grateful to our sponsors for making this event possible, and you can see who they are from our slides. So in the interest of time, I would like to get started because we'll have plenty of time at the end where we can work as a panelists to take questions. So the first talk is from Mohammed Al-Haj Ali, who's one of our international speakers, I should say, because he works in Cardiff. And he will take us through hypoglycemia in Ramadan. How significant is the problem? How can we mitigate against it? And what are the problems in relation to hypoglycemia in Ramadan? Mohammed, I really look forward to your talk. I know that you've worked as a clinical lecturer in diabetes for a long period of time. You have a special interest in this area, and you've also helped with many guidelines as well. So over to you, Mohammed.
Thanks, Vinod. And I'm very much delighted to be in this annual conference. And it's a great pleasure for me to be among this faculty, distinguished faculty. And I would like to talk to you today about hypoglycemia as a real problem for those who fast the month of Ramadan, people with diabetes. Welcome everybody to this talk, and Assalamu alaikum wa rahmatullahi wa barakatuh. I'm going to talk about hypoglycemia in Ramadan. How significant is this problem? These are my disclosures. Right. So these are the objectives of my talk. So to understand and to be able to describe how significant is the epidemiology of hypoglycemia in Ramadan. Secondly, to be able to describe the complications related to hypoglycemia during the month of Ramadan, and also to learn strategies and technologies to prevent hypoglycemia in the month of Ramadan. So the majority of Muslims, as you know, fast from dawn until dusk during the annual Islamic holy month of Ramadan. And the estimates suggest that there are about 148 million Muslims with diabetes worldwide. Up to 79% of Muslims with diabetes, they fast for at least 15 days in Ramadan. And that's quite a significant number of days. And that will lead us to think about the complications which could be related to that one in the people of diabetes. Decreased food intake is a well-known risk factor for the development of hypoglycemia. There are benefits, of course, associated with fasting in healthy individuals, and there's no doubt about it, including body weight, which typically decreases or remains stable. Fasting causes glucogenolysis. It causes as well gluconeogenesis, and it is associated with good effects as well on blood lipids. This is something we always need to remind ourselves and our patients with, and this is a verse from the Holy Quran, which is talking about the month of Ramadan as it's being prescribed for Muslims. And what I would like to emphasize here for healthcare professionals, those who are non-Muslims, and they're going to provide advice for people with diabetes, and they fast the month of Ramadan on this verse here, which says, and whoever is ill or on a journey, then an equal number of other days, which means they can fast in other days. Allah intends for you the ease and does not intend for you the hardship. And that's very important. So whenever there's illness or there's a problem or a risk of severe complication, then we need to think about it carefully here, as Allah subhanahu wa ta'ala, our Lord, intends the ease, not the hardship. The challenge becomes bigger and bigger when we look at the calendar and when we look at the hours of fasting, which can be prolonged hours of fasting. Sometimes in some countries, it may reach 18 hours of fasting or up to 20 hours, and only limited hours of non-fasting. And that will increase certainly some complications or risk of complications such as hypoglycemia. The risk associated with fasting for people with diabetes includes hypoglycemia as top of the list, hyperglycemia, dehydration, and also risk of thrombosis and acute metabolic complications, namely here DKA. So if I touch base on the first point, which is to understand and to be able to describe how significant is the epidemiology of hypoglycemia in Ramadan. This is the EPIDIA famous study, which was done and conducted in 2004, and that was done in 13 countries and included nearly 13,000 people with both type 1 and type 2 diabetes, the majority of them type 2 diabetes. 79 of patients with type 2 diabetes fasted more than 15 days during the month of Ramadan. If we look at the graph here with the overall population, we look at the severe hypoglycemia risk, which is very significant increase when we look at during Ramadan compared with the blue bar, which is before Ramadan. And when we look at those who fasted more than 15 days, which we assume that they are like a more stable population, people with diabetes here. So we still see a significant increase in the risk of hypoglycemia compared with the baseline before Ramadan. So in both cases, those who fasted less than, or the overall population in this study, and those who've been more stable and fasted more than 15 days, in both of them, we have a significant rise in the risk of severe hypoglycemia. And this is another graph as well, which shows the same study, but that will look at both type 1 and type 2 diabetes. And if you look at the bars there, if we start on the left side with the severe hypoglycemia in type 1 diabetes, there's 4.7-fold increase in the risk of severe hypoglycemia during Ramadan compared with baseline. If we move to type 2 diabetes, we still see that significant increase in severe hypoglycemia, and this is by 7.5-fold. So some people think that when we talk about hypoglycemia, it's only limited and restricted to type 1 diabetes. But in fact, it covers both type 1 and type 2 diabetes. And as you see from this study, the increase here in type 2 diabetes, it goes up to 7.5-fold. So touching base on type 1 diabetes patients here. So type 1 diabetes patients do not always recognize when they are hypoglycemic. And a study involving CGM noted variable blood glucose levels and significant periods of hypoglycemia that went unnoticed. Patients must monitor their blood glucose frequently during the day to prevent that one. And the few studies that have been conducted suggest that the risk of severe hypoglycemia event is low, but patient numbers are low as well. And this is a limitation in some studies when we talk about the monitoring all over the day. If patients with type 1 diabetes decide to fast, then adjustments are needed. So this is our advice when we talk about the type 1 diabetes population. And I put this slide here just to show you that when we talk about patients with type 1 diabetes who have following conditions, strongly advise not to fast. And the top two of them will be history of recurrent hypoglycemia or hypoglycemia unawareness. So both of them will put patients with type 1 diabetes as a high risk not to fast, and they should be strongly advised to avoid fasting during the month of Ramadan. This is a survey now looking at physicians' view on the risk of severe hypoglycemia and other factors as well. And this is when they looked at severe hypoglycemia within the 3 months prior to the month of Ramadan, how they looked at that one, whether this is like a very high risk or high risk, or a moderate low risk in green bars. And when we look at severe hypoglycemia within the last 3 months prior to Ramadan, you will see that the physicians there in this survey, so they put the majority of them, they put severe hypoglycemia as a very high risk or high risk. When we look at history of recurrent hypoglycemia as well, 93% of physicians there treating these patients, they thought as this is a very high risk or high risk. And also hypoglycemia unawareness, it's been nearly 90% of physicians scored that one as a high risk or very high risk. So this is a physician's view, which comes together nicely with the message I want to deliver here today, that they support the narrative that hypoglycemia unawareness or recurrent hypoglycemia or severe hypoglycemia within the last 3 months prior to the month of Ramadan, all that should be considered as very high risk or high risk to fast during the month of Ramadan. So moving to this second point here, which is to be able to describe the complications related to hypoglycemia in Ramadan. So these are the classical symptoms of hypoglycemia, starting with feeling hungry, headache, confused, dizzy, shaky, grumpy, all that stuff. But what confuses the picture here, that these symptoms as well may happen with someone who's non-diabetic as well, and especially in the first few days of Ramadan, when we start to have a bit of headache, feeling a bit shaky as well towards the hours of breaking the fast, and that sometimes puts more pressure on diabetic population who fast during the month of Ramadan, whether this is like related to fasting in general, or this is like really hypoglycemia, which they should treat and look at that carefully. And the spectrum of hypoglycemia, which starts with mild symptoms, may go to moderate to severe symptoms. And this is really the big red flag here for our population, Muslim population, who do fast the month of Ramadan and they have diabetes. And the main problem when they reach severe hypoglycemia, and this is untreated, in general, this is rare, but this is life-threatening, and if not treated promptly. And the symptoms of that one would include convulsions or seizures, loss of consciousness, inability to swallow. But as I said, fasting in general, I mean, for a normal individual, sometimes may carry the same starting symptoms as someone having hypoglycemia and having diabetes. The Diabetes in Ramadan Practical Guidance, which was published in January this year, brings a very lovely scoring system here. And I'm sure my colleagues in the previous session touched base on that one. And here, number 3 in the scoring system, they put presence of hypoglycemia. And as you see, hypoglycemia unawareness or recent severe hypoglycemia or multiple weekly hypoglycemia or less than 1 time per week. So these are how we score the presence of hypoglycemia. And as you see, hypoglycemia unawareness itself will score 6.5, the recent severe hypoglycemia 5.5. And if we go to the next slide here, if we look at the scoring system, as soon as we have like 6.5, that means high risk. So whoever having hypoglycemia unawareness, that will score them 6.5. Those with recent severe hypoglycemia, they moving from a moderate risk to a higher risk, having another score from another element in this scoring system. So the practical side of my presentation here is how to learn the strategies and technologies to prevent hypoglycemia in Ramadan, because that's what matters for all of us here. When we talk about hypoglycemia, this is something expected. This is something may happen in diabetic population, but how are we going to put strategies and guidance and general advices for our patients to prevent hypoglycemia? So I summarize them in this slide as pre-Ramadan assessment, pre-Ramadan education and awareness, exercise and lifestyle, talking about blood glucose monitoring, adjustments to oral anti-glycemic drugs, and adjustment to insulin, and lastly, breaking the fast when this is needed. So the pre-Ramadan assessment, preferably, there should be a pre-Ramadan assessment 1 to 2 months prior to Ramadan. And this is really very much recommended. Patients should be aware that carb binging may occur prior and during Ramadan. We have to provide patients with modified diet plan. This is aimed at improving the glycemic control during Ramadan. And also, there should be diabetic medication to be altered and adjusted in line with altered eating pattern here, especially when we talk about those who are on insulin. The importance of exercise should be highlighted here, and pre-Ramadan assessment is necessary to evaluate the risks, to educate the patients in self-management of diabetes during fasting, and to individualize treatment as well. And here, the scoring system comes as a very valid and a very valuable tool, really, when we give a plan for fasting or non-fasting for these patients. And I believe that scoring system should be put early, as 1 to 2 months prior to the month of Ramadan. And this is when we look at the scoring and then provide advice to our patients. The pre-Ramadan education has been shown to reduce the incidence of hypoglycemia, and we have evidence about that one. The pre-Ramadan education programs should be aimed at people with diabetes, healthcare professionals, public and community. And we started here in Wales an example of that one, which is Healthy Ramadan Camry. We started that this year, and this is aimed on 3 directions, as it showed in this slide. So to people with diabetes, to healthcare professionals, and to the community as well around these people with diabetes. The Ramadan Education and Awareness in Diabetes READ program. So Ramadan Focused Structured Diabetes Education. This is a 2-hour multilingual education sessions given 2 to 4 weeks prior to Ramadan. And that includes blood glucose monitoring, recognizing and managing complications, meal planning and diet, in addition to exercise. So what we see in the READ program here. So in terms of hypoglycemic events, those who received education, they have 44% reduction in the events of hypoglycemia compared with the baseline. Those who did not receive education, they have a 300% increase in the events of hypoglycemia compared with baseline. When we look at HbA1c levels, there was no significant change versus baseline in this study. And those who did not receive education, actually, they had a bit of increase as well, and that was significant in their HbA1c levels. But my focus here is on hypoglycemia events. So that education, that intensive education, which was given to patients, prevented hypoglycemia in a very significant way. The telehealth in Ramadan, it's an important thing, and DAR, Diabetes in Ramadan, provides lovely resources for patients, and that will include talking about the nutrition plan during the month of Ramadan, in addition to other advices, which is talking about the preparation for fasting, the potential risks, and also the bad eating habits, the weight management, and examples of Ramadan plates. So you see all that stuff in these applications. And I guess, this is our duty as healthcare professionals to provide and to publicize that application to all our patients, those who intend to fast the month of Ramadan. In terms of exercise and lifestyle, normal levels of physical activity are encouraged. Advise patients to avoid excessive exertion, as it may lead to episodes of hypoglycemia. And that can be a bit problematic in those who have like an intensive labor work, as that will lead to an increased risk of hypoglycemia. Walking to prayers and the act of praying are physical activities. And that's important, as these activities should be considered always part of the daily exercise program if they have to do that one. And this is when you discuss with them the pre-Ramadan assessment. Blood glucose monitoring, that's something very important. And we have recommended times or timing to check the blood glucose levels during Ramadan fasting. And this is at least 6 times during the day, starting from morning, sahur and dawn time, midday, sometime in the afternoon as well, iftar or sunset, and sometime in the evening between the iftar and sahur. And levels should be checked at any time when symptoms of hypoglycemia are recognized. And that will raise a question here, how important to provide the blood glucose monitoring even for patients with type 2 diabetes, as this is not something luxury, it's something to prevent hypoglycemia happening, especially when we have a bit of red flags in the story. Breaking the fast, patients should break the fast immediately if hypoglycemia occurs. And this is when we talk about a blood glucose level below 3.3 or less than 60 milligram per deciliter, even minutes before sunset. When blood glucose reaches less than 3.9, and this is less than 70 milligram per deciliter, in the first few hours after the start of the fast, they have to think about it, because especially if insulin or sulfonylureas or combination of drugs were taken at the pre-dawn meal. And this is when we talk about early hours during the day. So that means during the day, it will go down and down, and patients should break the fast here in this scenario. Treatment adjusting during Ramadan, there are different guidance, and there are like local guidances as well. But to put that one in a simple table as done by ADA years ago. So when we talk about diet and exercise, there should be a consideration to modifying the time and intensity of physical activity and ensure adequate fluid intake. In terms of oral hypoglycemic agents, there should be always a good fluid intake. And when we talk about metformin, those who are on 3 times a day, that can be adjusted to sunset and the pre-dawn meal. Those on TZDs or alpha glucosidase inhibitors, no change needed. Those on sulfonylurea, once daily, there's advice here to move on to the modern generation of sulfonylurea. The old generation of sulfonylurea always carries an increased risk of hypoglycemia. So when we talk about those who are on once daily, dose before the sunset meal, there should be a dose adjustment according to glycemic control here and hypoglycemia risk. Those are on twice daily. We can give half of the usual morning dose at pre-dawn meal and normal dose at sunset meal with blood glucose monitoring as well, just to see if there's any risk or increased risk of hypoglycemia during fasting in Ramadan. Insulin, there should be always adequate fluid intake, and there should be a consideration as well to change to long-acting or intermediate insulin in the evening. And there should be always a consideration here to adjust the dose and minimize the dose and keep eyes closely during the month of Ramadan. GLP-1 receptor agonists, no change needed, and they can continue on the same dose. So to conclude my presentation, fasting increases the risk of hypoglycemia in patients with type 2 diabetes who are on certain oral or injectable medications. Patients should be stratified in the risk of hypoglycemia and or the presence of complications prior to the beginning of fasting. Patients at high risk of hypoglycemia and with multiple diabetic complications should be advised against prolonged fasting. Patients with type 1 diabetes are advised not to fast due to the increased risk of severe complications. Multidisciplinary approach should be followed here to minimize the risk of hypoglycemia in people with diabetes who intend to fast Ramadan. Thank you.
Thank you very much for a wonderful talk. I think you've presented the subject beautifully from a practical and an evidence-based point of view, and I'd expect nothing else of you. I think it's quite striking how important education is in reducing the risk of hypoglycemia and also making sure that there isn't a deterioration in the hemoglobin A1C. So I'm sure that will come up later. So Mohammed, thank you very much for that talk, and we'll move on, and I'm sure there'll be many questions for you in the panel discussion.
Thanks,
so I'd now like to move on to another friend of mine. We move on to Sarah Ali, who works at the Royal Free Hospital in London. She's a clinical lead for diabetes in the Barnet diabetes community and specifically runs the diabetes services for patients with gestational diabetes and pre-existing diabetes. I think her claim to fame would be that she actually had so her artwork published in Nature Medicine, and that is something that I'm truly envious and jealous of. I'm really looking forward to your talk. It's quite topical because we're in the midst of the COVID-19 pandemic, and we've had 12 months of seeing our patients lose control. And it'd be really interesting to see how you think our patients should be approaching Ramadan during these times. So over to you, Sarah, and I'm sure there'll be lots of questions for you at the end as well.
So thank you very much, Vinod, for such a kind, generous introduction. And thank you to Vinod, Wasim and Mohammed for asking me to speak about such an important and topical subject. So before I start, I just want to reflect on last year's SAHF conference for diabetes in Ramadan, when I presented our recently published Diabetes in Ramadan guidelines, which are now available. However, that was a year and 2 weeks ago, and COVID-19 hadn't quite struck our shores. But soon after, 2 weeks later, the COVID-19 pandemic hit the UK, and we soon realized the association between diabetes and COVID-19. And as a result of our rapidly growing experience of how diabetes was an independent risk factor for severe illness in COVID-19, we felt that it was necessary to update our diabetes and Ramadan guidelines, and we subsequently published them in Diabetic Medicine, which are free access, and they were published just before the start of Ramadan 2020. So I don't need to tell everyone, I'm sure everyone appreciates how serious a global threat to health COVID-19 has been. But COVID-19 is a severe acute respiratory distress syndrome caused by SARS-CoV-2, which is a beta coronavirus, and can cause serious systemic disease. In particular, we know that it has affected 124 million cases globally, and that there have been 2.74 million deaths to date. However, the global vaccination program has really given us some hope. So over the last year, it became apparent that there were several factors that increased the risk of severe illness from COVID-19 infection. And this infographics summarizes these risk factors. And this was from our SAHF report last year, which looked at COVID-19 infection in ethnic minority groups. And we recognize that there are some risk factors that increase your risk of severe COVID. So that was age, male sex, but also comorbidities, including diabetes. In addition to this, we realized that certain ethnicities, of which Muslim populations, a significant portion are Muslim populations, are at increased risk from severe disease of COVID-19. So this is a study that sort of early on in the pandemic, it was realized that if you had diabetes, both type 1 and type 2 diabetes, that there was an increased risk of death from COVID-19. And that 1/3 of COVID-19 deaths in hospital were in people with diabetes. Now, the risk of diabetes is also, just to clarify as well, it is important to realize that glycemic control is relevant. And so if you have suboptimal control, but also additional comorbidities, that will increase your risk of severe illness from COVID. So how does that link with Ramadan fasting? Well, we know that fasting is compulsory for all adult Muslims, but there are exemptions, and those exemptions include chronic diseases such as diabetes, but also acute illnesses, which include infections, and I would really emphasize that that does include COVID-19 infection. However, we should recognize that some people will choose to fast regardless, and it is our duty to help advise them, to explain the risks and to manage them so that they can fast safely. So again, I just want to highlight this paper, which is available. So please go away and read this, and I'm going to present the guidelines from this, but this is free access. So we know about the risks of fasting in people with diabetes outside of Ramadan includes hypoglycemia, and medical diabetic emergencies such as diabetic ketoacidosis, hyperosmolar hypoglycemic state, and also dehydration and thromboembolic disease events. So that's outside of the COVID-19 pandemic. Now, we know from our experience over the last year that people with diabetes who developed COVID-19 were at increased risk of having severe illness, but in particular were presenting with diabetic ketoacidosis, starvation ketosis, and HHS. And that's outside of the context of fasting. So if we consider our people who have diabetes, if they were to fast and then developed a concurrent COVID-19 infection, you would assume that the risks of these complications will be worse and the outcomes will be poorer. So it is really important that we recognize this as healthcare professionals, and that we are able to advise our patients, our people with diabetes, so that they can fast safely, but also give them the information so that they can make that decision. And that when people are informed, they're more likely to agree and not fast. But also to remind them about the times when to break your fast, and what invalidates and does not invalidate fasting. And I'll come to all of these points in the next few slides. So when we think about fasting in people who have diabetes, we think about risk stratification, and you've heard about that throughout the day. And we think about several factors. So the type of diabetes they have, the treatment they're on, if they're on insulin or oral hypoglycemic agents, have they had hypoglycemia outside of Ramadan, but also previous Ramadan experience. And I think in the context of COVID-19, we now have the benefit that we've already had one Ramadan in the pandemic. And so it is appropriate for us to ask, what was their experience in the last Ramadan during COVID? And did they have problems? Because that would guide you on whether they should fast or not fast in this coming Ramadan. So we've heard about risk stratification and the calculator the IDF have produced. But what I just want to highlight is in our table, which was created before the IDF guidelines were updated, the risk calculator was updated, is that we've added in each of the sections a line about COVID and when you'll be high risk, moderate risk, and low risk if you develop COVID-19. And people with high risk are those that are COVID positive or have symptoms of COVID, and they should not fast, they must not fast. Those that are living in the same house as someone who has COVID would be moderate risk, and they would be recommended not to fast. But then those that are not affected by COVID and well controlled should be able to fast. So we know that finger pricking during Ramadan does not invalidate the fast, and like outside of the pandemic, it is important to continue with the frequent home blood glucose or glucose monitoring, whether that be finger pricking or with the flash devices or the CGM. But it's important to remind people that if they become unwell with symptoms of COVID-19, that they must check their blood glucose levels frequently and also break the fast. And if they have type 1 diabetes, then they must be checking their blood ketones. So the usual rules for breaking fasts apply during the pandemic, but we've added guidance about if people develop any symptoms of COVID-19, including high fever, persistent cough, and loss of smell. But I would also include the GI symptoms of diarrhea and vomiting, that if they develop these symptoms, that they must stop fasting. They must break their fast immediately because they could become very unwell. So then just some general recommendations with people with diabetes, that if they, I cannot emphasize this enough, if they develop any symptoms of COVID, they should not fast. And that even we've heard that for people with type 1 diabetes that they may want to fast, but we would really recommend to them that if there is a high transmission of COVID-19 in their region or their country, that they should not fast. And just to remember that if they that they should be checking their glucose levels regularly. If they develop any symptoms, to break their fast. If they have type 1 diabetes, that they must also check for their ketones. And we've discussed previously about fluid intake, and it is really essential to drink enough fluid outside of fasting, because dehydration it's possible to become very dehydrated when you're fasting, especially in the long fasts in Europe. And dehydration and acute kidney injury may be a reflection of becoming more unwell with COVID-19. So lifestyle considerations during the pandemic are pretty much the same as outside of the pandemic, but again, it's the emphasis of making sure that they do not become dehydrated. And then I just wanted to highlight physical activity. So physical activity is generally reduced during Ramadan, and for a number of factors. And we've heard from previous talks that physical activity is beneficial for reducing weight gain. But I think it's really important to also emphasize the benefits that it has on improving mood. We've known that traditionally Ramadan is a time, is a social time, it's communal, and because of the COVID-19 pandemic, it's become more isolating. And if people were to take light exercise within the governmental regulations, this may help with mood and help with the feelings of anxiety that are associated with the pandemic. So I'm now just going to move on to the pharmacological management of diabetes for people who want to fast during COVID-19. And in the interest of time, I'm not going to go through the dose adjustments because we've heard that before, but I'm going to highlight the significant points about COVID-19. So with metformin, sulfonylureas, DPP-4 inhibitors, we've heard about how to adjust the doses, but I just want to highlight with metformin that if you develop severe symptoms from COVID-19, then that metformin should be stopped, and it would certainly be stopped if they were to be admitted with COVID-19, and that is because of the increased risk of lactic acidosis with infection, but also if they develop severe COVID-19, they may have a acute kidney injury. With pioglitazone and GLP-1 receptor agonists, there is no change in dose if these individuals are worried about the COVID-19 pandemic. However, if people, or if they develop symptoms, they can continue it. However, if they, with the GLP-1 receptor agonists, if they develop any GI symptoms, which include diarrhea or vomiting or reduced appetite, loss of taste, then it's advisable. Our recommendation would be to stop the GLP-1 receptor agonist, because they will, as a result of the effects of the GLP-1 receptor agonist, is a reduce in appetite and an increased risk of starvation ketosis if they develop severe COVID-19. There is no dose adjustment with the SGLT2 inhibitors, but I'm just going to come back to that in one moment. So with insulin, the thing to remember with COVID-19 is that if individuals become unwell with symptoms, that they must stop fasting. They must break their fast immediately. They must be checking their glucose levels regularly. And if they've got type 1 diabetes, then they should be checking their ketones regularly, and that they should follow sick day rules for insulin. And in particular, if they have diarrhea or vomiting or reduced in oral intake, then they will, because of the insulin, there are increased risk of hypoglycemia. So it should ensure that they're keeping well hydrated, and particularly may need to take sugary fluids and keep a regular eye on their glucose levels, and have a low threshold to seek urgent medical attention. So just coming back to the SGLT2 inhibitors, these are the concerns just in general during fasting. So this is outside of the pandemic. And if we think about the pandemic, the two things that are particularly concerning are the risk of dehydration and the risk of euglycemic diabetic ketoacidosis. So if someone were to develop COVID-19, those are the two things that we're particularly looking out for. So it is important to just ensure that the people that are on these agents, when they fast, that we've appropriately selected people that will know how to manage their sick day rules and be able to monitor for hydration status. So looking at the color and the volume of urine, and that they're making sure they're drinking enough fluid outside in the non-fasting hours. And then if individuals develop any COVID symptoms, our strong recommendation is that they must stop the SGLT2 inhibitor, as you would do for any infection. So stop the SGLT2 inhibitor with any signs of infection, and only restart it when they're well and eating and drinking normally. And that is because that they are increasing the risk of developing euglycemic DKA. So the sick day rules also apply to several other medications that our people with people with diabetes may be on. And so these are just a reminder of the SAD-MAN rules. And so that's ACE inhibitors, diuretics, metformin, ARBs, and non-steroidals, in addition to the SGLT2 inhibitors. So I just want to come onto the topic of the COVID-19 vaccinations. So we've had a fantastic worldwide rollout of the COVID-19 vaccination program. But what it means is for the 1.9 billion Muslims worldwide, their first or second vaccination may be offered during Ramadan. Now, Ramadan fasts require us to abstain from nutrition during daylight hours, but actually there is a specific term that's often used, which is refraining from anything entering the body cavities. So whilst for many people this means nutrition or medicine, some people may take this to mean injections. So there is little global information surrounding vaccine hesitancy around Ramadan, and that's because there haven't been no vaccination programs that have been rolled out with such urgency prior to the COVID-19 pandemic. However, from our previous experiences with the Ebola and polio vaccination programs, it highlighted the role of the religious leaders in educating and supporting their worshippers and their communities. So in particular, we have had recent announcements by Muslim scholars throughout the world, but particularly from the president of the two most holiest sites in Islam, that the COVID-19 vaccine is permissible during Ramadan, does not invalidate or break the fast. However, we should anticipate that there may be some people who may still not want to be vaccinated during fasting hours for whatever reason. And so for solutions for that would be to extend the vaccination times to include hours outside the Ramadan fasts. So, and also using mosques as vaccination sites, so that in places where people are able to go to the mosques for the special Ramadan nightly prayers, Tarawih, will be able to have their vaccinations outside of those fasting hours. It is important as healthcare professionals, but also our community and religious leaders, to address concerns about vaccination-related side effects. And yes, it may mean that they have to break their fast if they develop those side effects. However, those side effects are transient if they do happen, and they are less severe than if those individuals were to develop COVID-19 during Ramadan. And to remind people that vaccinations are our greatest tool to aid us back to normality, to celebrating future Eids and future Ramadans, so that we can go back to normal Ramadan practices. Very briefly, lateral flow tests for COVID-19. So this is from the British Islamic Medical Association, who've undertaken work with a number of Islamic scholars from different schools of thought. And this is just to emphasize that the COVID-19 PCR or lateral flow tests do not invalidate the fast during Ramadan. And then lastly, I just want to finish off with two surveys that show the experiences of people in the last Ramadan during the COVID pandemic. Now, this survey is from Dr. Tehseen Chowdhury, who we heard from earlier from East London, discussing with 829 participants with type 2 diabetes. The significant thing to point out from this is that there was only a small number of people that were admitted to hospital with diabetes, COVID and fasting related issues. But more significantly for me was the fact that those individuals who were not advised to fast by their healthcare professionals did not fast. So that really emphasizes the importance of the discussion between the healthcare professional and the person with diabetes, because that will guide them to their risk of fasting and whether they should fast or not fast. And this is a survey that we carried out, South Asian Health Foundation carried out in the general population on experiences of fasting and Ramadan and the COVID-19 pandemic. And this is in the general population, so people necessarily didn't have any medical conditions. And this is just to show that the vast majority of people did not need to contact a healthcare professional and fasted safely. Now this, apologies, this is a bit busy, but this is hot off the press, or analysis press, but this is really just to emphasize that a lot of people were worried about themselves or their loved ones developing COVID-19 symptoms, and that they also found that Ramadan was more isolating than usual. And this is really to just emphasize the fact that we should encourage people to take their vaccination so that we can return back to normal Ramadans. Thank you.
Right. Sarah, thank you very much for that amazing talk. You covered a very large area there, and you succinctly summarized everything to do with COVID-19 and how this has changed the management of diabetes generally, but more specifically during Ramadan. I was really particularly pleased about the fact that you mentioned that vaccines can be given during Ramadan, and also the fact that testing can take place as well, because especially in UK, we're opening up vaccination to the younger age groups now, and many of our patients who are South Asian and have diabetes are now being called for vaccination, particularly if they're under the age of 50. So I'm very grateful for that. I can also confirm that the UK imams specifically are endorsing vaccination and testing, and there is absolutely no controversies at all when it comes to the management of COVID and its prevention in terms of Islamic practices. So that was a great talk, Sarah, and I note that you qualified from Oxford University. So we now move on to a speaker from Cambridge University, who is also a friend of mine. All of these people appear to be friends of mine, but they were picked independently and not by me, I can assure you. The next talk is from Yasser Javid, who works as a general practitioner in Northamptonshire, but he has many other accolades as well. He works both in primary care and secondary care, and he works in cardiology with a very specific interest in echocardiography. And he will be delivering our sponsored symposium, and this was kindly sponsored by AstraZeneca, who are the makers of dapagliflozin. But I think this is a really exciting topic, heart failure and type 2 diabetes, particularly with the new agents. I should also point out that Yasser, being a cardiologist, was appropriately named the Pulse magazine's GP of the Year in 2015 because of his work with atrial fibrillation and reducing the risk of stroke in the East Midlands particularly. So without any further ado, I'd like to hand over to Yasser for his talk. And we will have a few minutes, we think, for questions at the end, because then Yasser will be leaving our afternoon deliberations. So Yasser, over to you. Type 2 diabetes and heart failure, a risk worth managing.
Absolutely. Well, thank you very much, Vinod, for that very kind and flattering introduction. It's a pleasure and honor to be a part of this wonderful agenda. Thank you to the organizers for the opportunity. So look, cardiovascular disease remains the single biggest killer in our population. That's been true for a very long time, pre-COVID, during the pandemic, and certainly will be in the post-COVID era. And cardiovascular disease, of course, has a heightened importance in our patients living with type 2 diabetes, because it's clearly the leading cause of premature mortality and significant morbidity and disability in these patients. The sobering fact is that the majority of our patients living with type 2 diabetes lose many good quality of life years to cardiovascular disease, often a decade more than their non-diabetic counterparts. And our job as clinicians is to try and claw back as many of those lost quality of life years as possible. And heart failure really does often represent the end stage of the cardiovascular trajectory. It's a clinical syndrome driven by multiple cardiometabolic risk factors, which often coexist, such as ischemic heart disease, hypertension, and of course, diabetes. Around a third of heart failure patients admitted to hospital in the UK have type 2 diabetes. It's clearly a huge driver to developing heart failure, as well as being associated with far worse outcomes. And heart failure itself carries a prognosis worse than many cancers and is associated with huge downstream healthcare costs, driven predominantly by admissions, and many patients a revolving door of readmissions. Most importantly, though, it carries huge human costs. Because patients can often present with this crippling breathlessness. I think this is the reason I'm so passionate about heart failure. It's a huge quality of life issue for these patients. Patients often describe this breathlessness as a feeling of drowning, which really is far more distressing than severe pain. Daily activities, hobbies, and quality of life are often severely compromised. And then tragically, there is often a progressively disabling, increasingly possible ways to die. However, The flip side, more so than ever, managing type 2 diabetes and heart failure well is an opportunity we simply must not miss. We
Yes,
have
sir.
multiple
Sorry to
effective
interrupt.
tools now in the
Yes,
heart failure toolbox, and together with early diagnosis, aided by liberal use of NT-proBNP in our diabetes reviews to those years, and reduce this crippling burden of hospitalization. These are my disclosures. And today we're going to have a particular focus. I want this to be very fair and balanced, but a particular focus on one treatment option, a drug familiar to many of us in the setting of the management of type 2 diabetes, dapagliflozin, an SGLT2 inhibitor. We'll explore its efficacy, simplicity, and impressive data in improving heart failure related outcomes. And these data, very exciting, this actually, have now led to a new license, a new NICE guidance. I can tell you, some of my cardiology colleagues in secondary care are getting incredibly excited because this guidance is now for its use to improve outcomes in patients with heart failure, irrespective of the presence of type 2 diabetes. And we'll explore how this will impact our clinical practice, and we'll also try and support you in identifying those patients at high risk of developing heart failure. So dapagliflozin, like all SGLT2 inhibitors, was initially developed as a glucose lowering agent and has had a therapeutic indication for insufficiently controlled type 2 diabetes. Clearly, we all understand the added benefits of blood pressure lowering, weight loss, and increasingly now familiar with the renal protection data. However, two landmark trials, declared TIMI and more recently DAPA heart failure, have shown very positive heart failure related outcomes. And this has led to a new approval and therapeutic indication for dapagliflozin in patients with symptomatic heart failure with reduced ejection fraction. So I think dapagliflozin does help to facilitate this, increasing cardiorenal metabolic focus that we should be having on our management strategies, and perhaps moving away from that glucose centricity. And very hot off the press and so exciting, this recent NICE technical appraisal approval. So NICE now recommends dapagliflozin to be used on the advice of a heart failure specialist, and by no means does that mean mandate a referral to a specialist, but on the advice of a specialist as an add-on to otherwise optimized standard of care like ACE inhibitors, beta blockers, and if tolerated, mineralocorticoid receptor antagonists like spironolactone in patients with symptomatic heart failure with reduced ejection fraction, irrespective of diabetes status. And I think that's remarkable for a drug that was initially designed to just lower glucose. It's the first and so far only SGLT2 inhibitor with NICE approval for this specific use. And I think it just makes it another very useful tool in the heart failure management toolbox to further incrementally improve outcomes. Let's just remind ourselves, though, what we mean by heart failure, because our understanding has evolved considerably over the last few decades. Nowadays, we definitely think of heart failure as more of a clinical syndrome where structural and functional changes to the heart impair its ability to function as a pump and reduce cardiac output. There are essentially two types of heart failure, distinguished by the left ventricular ejection fraction, which is essentially the percentage of blood within the left ventricle expelled following contraction or systole. In heart failure with reduced ejection fraction, or HFrEF we call it now, there is systolic dysfunction of the heart defined by an ejection fraction, left ventricular ejection fraction, of less than 40%. In heart failure with preserved ejection fraction, or HFpEF, essentially what's happened there is the left ventricle has become stiff and struggles to relax normally, compromising its filling. And the left ventricular ejection fraction, however, remains preserved above 50%. But sadly, unlike for HFrEF, there are still no proven prognostically beneficial or licensed treatments for HFpEF. And it's a very sad state of affairs. Half of my heart failure patients have HFpEF. And I truly think that's the real cancer of cardiology, a condition with such a poor prognosis with no prognostically beneficial licensed treatments. And heart failure consumes, let's look at health utilization. I mean, it consumes 2% of the total NHS expenditure in this country, which is largely driven by hospitalizations, both admissions and readmissions, totaling around 65,000 unplanned admissions per year in the UK. But patients with type 2 diabetes as a comorbidity have a particularly bad outcome with significantly increased risk of hospitalization for heart failure or death compared to their non-diabetic counterparts, and a 50% mortality within 5 years of developing heart failure. As I said, that's far worse than many cancers. And sadly, the COVID-19 pandemic has posed multiple significant challenges to managing patients with type 2 diabetes and heart failure. We know following the first lockdown in March 2020, there was a significant increase in delayed diagnoses of type 2 diabetes, quite a significant reduction in HbA1c and other testing, and sadly and not surprisingly, a huge increase in mortality rates for people living with type 2 diabetes. But just before the pandemic, we had this wonderful trial, the DAPA heart failure trial. We use the term landmark study, I think, quite liberally in medicine, but this really was a landmark study. And Professor McMurray, the godfather of heart failure, in my opinion, globally, really called this a once-in-a-lifetime breakthrough in heart failure treatment as a result of this study, looking to assess the impact of dapagliflozin in patients with symptomatic HFrEF. So in this study, just over 4,700 patients with symptomatic HFrEF, in other words, ejection fractions less than or equal to 40%, raised NT-proBNPs, EGFRs down to 30, were randomized to either dapagliflozin or placebo on top of stable treatment. And the primary endpoint was a composite of cardiovascular death or worsening heart failure, essentially the key clinical outcome measures that we look for in heart failure. And the results were just spectacular. I mean, the trial was stopped early at 24 months because of the overwhelming benefit seen in the dapagliflozin arm. I still remember the goosebumps we all felt in the auditorium at the ESC in Paris when this was presented. And what was most striking was how early the benefit was seen. Statistical significance, I'll just highlight this, you get statistical significance very, very early on, within 28 days, an overall absolute risk reduction of 4.9%, giving a numbers needed to treat of only 21 to prevent one of these primary endpoints over 24 months. And remember, the benefit was on top of fantastic standard of care. 94% of patients in this study were on an ACE inhibitor or ARB or angiotensin receptor neprilysin inhibitor. 96%, almost unheard of, were on beta blocker therapy, and 71% on a mineralocorticoid receptor antagonist. That's far better than we would typically see in real-world UK clinical practice. And the benefit of dapagliflozin seen on this graph was incremental to that standard of care. And when we look at each component of the primary endpoint, cardiovascular death and worsening heart failure, both were statistically significant, reductions on top of that excellent standard of care. And the majority of patients, 58%, this is what got cardiologists very interested, 58% in the DAPA heart failure study did not have type 2 diabetes at baseline. And again, of huge interest was that the benefit of dapagliflozin in this study was seen with statistical significance in both cohorts, patients with and without type 2 diabetes at baseline. You can see very similar results here, irrespective of diabetes status. And moving on to the secondary endpoint, of all-cause mortality, again, very impressively, a significant benefit seen with dapagliflozin. And for me, all-cause mortality is the ultimate endpoint in any outcome study, because that's actually showing there were fewer deaths from any cause in the dapagliflozin arm, essentially showing that patients on dapagliflozin were living longer than patients not on dapagliflozin in this study. Very hard to demonstrate in contemporary cardiovascular trials, particularly when the standard of care is clearly so good. And moving away from the incredibly impressive hard clinical endpoints, I think it's also reassuring that in DAPA heart failure, there was also good evidence of improved quality of life measures, including improved physical and social functionality. Having looked at the benefit and efficacy, it's also reassuring to see no significant or worrying safety signals with use of dapagliflozin in these patients in this study. Reassuringly, no increased treatment discontinuation compared to placebo. There was some concern amongst cardiology colleagues initially, if we use an SGLT2 inhibitor, which, let's face it, does have a significant osmotic diuretic effect in patients with heart failure, will this lead to issues relating to volume depletion? But again, reassuringly, this was not a significant issue. And I'm happy to answer at the end any practical questions relating to use of dapagliflozin in heart failure patients in conjunction with loop diuretic therapy. There are a few practical tips that perhaps we can pass on. And so I think we must be proactive nowadays, and modern cardiometabolic management really must be to hunt for patients at the highest risk of developing cardiovascular disease, particular heart failure. Both type 2 diabetes and hypertension are significant independent cardiovascular risk factors, but in combination, they're far more devastating. And hypertension is a common component of the metabolic syndrome. If you look for it, it's going to be present in at least 3/4 of patients with type 2 diabetes, placing these patients at very high risk of developing heart failure later on in life. So intervening early in type 2 diabetes, this is going to be the key to improving outcomes. The modern definition of uncontrolled type 2 diabetes, I'm afraid now has to go far beyond just glycemic control. And we must include other risk factors like hypertension. So it's important to look at the benefit of upstream intervention. And dapagliflozin has evidence for preventing both hospitalization for heart failure and cardiovascular death, even when used earlier on in the trajectory. And that's where the Declare TIMI trial is quite interesting, because this trial preceded the DAPA heart failure trial. You're all familiar with this trial, a huge landmark study, 17,000 patients, still to date the largest cardiovascular outcome trial with an SGLT2 inhibitor in type 2 diabetes. The patients recruited had type 2 diabetes with either multiple risk factors like hypertension, dyslipidemia, or tobacco smoking, or they had confirmed established cardiovascular disease. However, important to note, the majority were primary prevention patients, and they were randomized to either dapagliflozin or placebo on top of standard of care for both their glucose control and cardiovascular prevention. And the median average follow-up was just over 4 years, and co-primary endpoints of obviously MACE, major adverse cardiovascular events, and a composite of hospitalization for heart failure or cardiovascular death. And I think what really stands out in this trial compared with the other SGLT2 inhibitor cardiovascular outcome trials was the predominance of patients without established cardiovascular disease at entry. About 60% were essentially primary prevention patients, but with multiple risk factors. And this is really a population that's very familiar, certainly to me and most of my colleagues in UK primary care. So look, although we're all aware there was no statistically significant reduction in MACE seen with dapagliflozin, I think not really surprising considering this enriched primary prevention population. But now that we've got the DAPA heart failure trial results, I think this becomes very relevant, that we saw an impressive significant reduction in the other co-primary endpoint of hospitalization for heart failure or cardiovascular death. 17% relative risk reduction, but more importantly, 0.9% absolute risk reduction at 4 years. And when we just look at the hospitalization for heart failure, which was an exploratory endpoint, so nominal p-values here, but we can still see this early and what looks like a significant benefit for dapagliflozin on the population studied. And again, reassuring safety and tolerability, scenes, clearly a small but definite increased risk of DKA. All SGLT2s have this with type 2 diabetes, why it's so important to reinforce those sick day rules. And we also saw, like other SGLT2 inhibitors, that increased risk of genital infections. So I think in our current environment, with more virtual working poses its own challenges, simplicity in dosing is another issue that I think needs to be discussed, because probably more important than ever before. And it's a bonus that we can actually initiate dapagliflozin straight onto the evidence-based therapeutic dose of 10 milligrams once daily without any requirement for dose titration, therefore not suffering from the clinical inertia seen with other drugs requiring up titration. And the dapagliflozin dosing of 10 milligrams once daily is now consistent across all indications. But for patients with insufficiently controlled type 2 diabetes, I think it's well worth highlighting the different EGFR cutoffs for initiation. So for initiation in type 2 diabetes, EGFR has to be more than 60, but can be continued down to 45. For patients with symptomatic HFrEF, there is actually technically no EGFR cutoff for initiation and no requirement to discontinue, no lower threshold. However, I think it's important to note there is limited data for use in patients with eGFRs below 30, and certainly no patient was entered into the DAPA heart failure trial with eGFRs below 30. And here's now a summary. Again, I'm sure you're all familiar with the well-established safety profile. It's amazing how much data we now have from randomized controlled trials, and increasingly now, probably more important from a safety perspective, that post-marketing surveillance. So SGLT2 inhibitors, you know that they only potentiate the risk of hypoglycemia when used in conjunction with a sulfonylurea or insulin. We've talked about that risk of genital infections. Tends to be front-loaded, and the small but definite risk of euglycemic DKA. And many associations now, in addition to NICE, have endorsed this early use of dapagliflozin in patients who remain symptomatic. ABCD, British Cardiovascular Society, the Primary Care Cardiovascular Society, of which I'm a proud member, the PCDS, the Renal Association, the British Society for Heart Failure. Look at this algorithm now. They're all standing united on this recommendation as part of the CareMe group, fostering this greater cardiovascular, renal, and metabolic collaboration. So I'm just going to wrap up this presentation, if you don't mind, with highlighting and summarizing some of the key points. So in addition to its license for insufficiently controlled type 2 diabetes, dapagliflozin now has this new license for use in patients with symptomatic chronic HFrEF. Heart failure is associated with a significant number of hospitalizations, and we must remember it's the most common cause of death in our patients with type 2 diabetes. Both DAPA heart failure and DECLARE, really, when you look at the data in conjunction with each other, it demonstrates evidence that supports the early upstream use of dapagliflozin in patients living with type 2 diabetes and at risk of developing heart failure. These studies also provide reassuring reinforcement of the well-established safety and tolerability profile of dapagliflozin, and I think it is important to highlight the simplicity of the 10 milligrams once daily dosing, which we certainly don't have with other heart failure treatments that are licensed. So NICE have assessed these data. We've got that NICE technical appraisal approval. By the way, NICE TAs, very robust. They look at efficacy, safety, and really crucially, cost effectiveness. And they have given this endorsement to dapagliflozin to be used as an add-on to otherwise optimized standard of care in patients with symptomatic HFrEF. So for me, the SGLT2 inhibitors, I think they're the most exciting class of drug therapy, not just in diabetes, but also cardiology and possibly medicine in general. If you look at the data that's now coming out. And dapagliflozin is now the first and so far only SGLT2 inhibitor with NICE approval for this use in heart failure. We've got another very effective treatment that we can use in HFrEF that can potentially add both quantity and quality of life for our patients, as well as making a significant dent in the huge burden of associated healthcare utilization costs and hospitalizations. Thank you very much for your kind attention.
Yes, so thank you very much for that amazing talk. I admire the enthusiasm that you have for this group of agents, and especially so because we found those benefits on top of existing standard of care, the beta blockers, the ACE inhibitors, the ARBs and the mineralocorticoid antagonists as well. And also the data applies to people with and without diabetes, which I think is truly important as well. And I'm sure that you'll be moving on to reducing admissions with heart failure and cardiovascular morbidity and mortality in patients locally and with your influence nationally as well. We've got time for just 2 or 3 questions only. So could you please ask if there are any questions, can you please put them in the chat box? Otherwise, we do have 1 or 2 questions already. So one question here is there any benefit in using these drugs in patients who do not have reduced ejection fraction?
Well, there's clearly a benefit in patients with insufficiently controlled type 2 diabetes. We got that from the DECLARE TIMI trial. So technically that heart failure was not an entry criteria. We haven't got data yet in patients with HFpEF. I mean, that's potentially an exciting innovation to come in the future. But I just want to make the point, all heart failure treatments, their benefit is actually far greater the earlier you start these drugs, because a lot of these drugs work by preventing, and I think we've got good data with dapagliflozin, or preventing cardiac remodeling. So the earlier you give it, the better. So I'm strongly encouraging now that we should be trying to pick up heart failure, early heart failure, as part of a routine diabetic review. It should be part and parcel of a diabetic review to ask about symptoms, identify that patient with a slightly reducing effort tolerance. And we've got the best screening test in medicine. The NT-proBNP blood test has a 99% negative predictive value for heart failure, £12 test in the UK. I mean, I'm liberally using it in my patients with type 2 diabetes. And when we get that elevated BNP, we go straight for the echocardiogram to see if we can pick up the heart failure early. Then you can double the life expectancy of a heart failure patient. If you extrapolate all of the data, you can double the life expectancy of a heart failure patient by giving them all the great treatments we have.
Double the life expectancy. That's an amazing statistic.
Amazing statistic.
Yeah, it truly is. Yes, just another question, especially because this conference is obviously on diabetes and Ramadan. So if you had a patient with heart failure, so maybe relatively mild heart failure, and they're quite adamant that they wanted to undertake Ramadan, and on a loop diuretic in the morning together with an SGLT2 inhibitor, would you change that those medications at all in that patient?
I think that's a difficult question. I personally think if you've got, I like the way you call it mild heart failure. In my opinion, there's no such
slightly pregnant, yeah.
It's no such thing as mild heart failure. It's like being mildly pregnant. You're right. It's impossible. But I would be, you know, I'm not a scholar by any stretch, but I'd be saying once you've got heart failure, particularly reduced ejection heart failure, I'll be trying to encourage my patient to probably not fast, because that delicate volume, we're trying to manage the volume so carefully in our heart failure patients. And I just think fasting just adds a serious extra layer of complexity. But no, I mean, if a patient insisted, obviously it's their right to continue with that, then I don't think I would change it drastically. I might just rein in the diuretics depending on what their volume status actually is, which is why it's so crucial that heart failure patients do one thing for their clinicians: buy a set of weighing scales and weigh themselves at the same time each day after micturition, just so we get a really good idea of their volume status, fluid status.
And just moving towards the end, just in a few sentences maybe, what do you think the mechanism of benefit is with this group of agents in heart failure?
Oh God, this is a $64 million question. I mean, it's clearly multiple benefits, but we know it's benefits way beyond just blood pressure lowering, weight loss, and clearly we now know it's beyond glycemic control, because we got this benefit in non-diabetics. Lots of postulated theories, ketone bodies being generated, which we know does preserve the pumping efficiency of the heart. It's way more than just as an osmotic diuretic. But I don't want any of us to be too fixated about the mechanism. I'm going to tell you right now, the most effective drug we have in heart failure in terms of prognosis is actually beta blocker therapy. You can ask 5 heart failure professors, how do beta blockers improve prognosis in heart failure? And you'll get 5 different answers. Yet they are absolutely mainstream drugs that we use in heart failure. We don't actually know 100% why they offer such great benefit. And as far as I'm concerned, it doesn't make a difference to me how they work. We just know they do work, and they work quite spectacularly.
Thank you, Yasser. Thank you very much for that endorsement of using dapagliflozin in heart failure. And thank you very much for showing the data so succinctly and with so much passion as well. So in the interest of time, we'll move on and thank AZ for providing this sponsored symposium, which I'm sure you'll all agree was very interesting and had very exciting data as well. And there's now compelling indications for using this drug and this group of drugs to reduce cardiovascular morbidity and mortality in our patients with type 2 diabetes and for cardiac failure, even if they don't have type 2 diabetes. So we'll move on to the next part of our afternoon. And next we will have, for around about 5 to 10 minutes, we're going to invite Mohammed Ismail to give his perspective on observing Ramadan for the first time. So this will be a personal viewpoint. So Mohammed, if I could ask you to take over on your experiences of first time fasting, your experiences and the lessons that you learned. So over to you, Mohammed.
Thank you. So thank you very much for the invite. I attended the event last year, and from that I kind of learned kind of a lot about what's out there, and people were talking about diabetics being able to fast around this time, and it's something I'd never done in my life. So I've been diabetic for a long time, about 20, from last year, about 27 years. And I was diagnosed age 2.5. I've been on a pump for a very, very long time, and I only use Nova Rapid. In June 2019, I was very fortunate. I got a DOI closed loop system, and using that, it helped my control, and I just wanted to give it a go. I know it's COVID time and all this. So I contacted some of the doctors on the panel last year to ask, is it a possibility? And they kind of directed me towards a voluntary trial that was going on. So I just want to talk through some of the challenges I faced and kind of went through. So this doesn't constitute to medical advice. So it was a voluntary thing to do. I've got a medical background as well, so I thought I'd be able to manage it well. I love sport and I love looking at ways to make my health better. So I just want to demonstrate kind of the system I use, which is Android APS, and that shows my blood glucose over 24 hours. This was the day before I started fasting, so I'd done no prior kind of arrangements or testing. And already you could see in the afternoon I hypoed. So it was kind of a good experience. I cut back. I had to stop my fast, which was obviously the thing you have to do, never soldier on. From there, I kind of reduced my basal, and then I kind of went on from there. These are graphs showing my first week of fasting. So I just wanted to demonstrate to people kind of watching that I was working at this time, and I have an artificial pancreas system, and it just shows that it's worked so hard to kind of sort me out during the daytime when I'm fasting. And I noticed a very tricky kind of management situation towards the evening when we broke kind of our fast. I noticed as I kind of took my insulin, I had to take a huge amount more than I normally do. And as you can see from the evening, that kind of carried on to the morning. So there was loads of adjusting to do. First time ever doing it. So dehydrated, tired, the stuff everyone else goes through that you've never been through. So that was an amazing experience. So from that first week, we kind of tried to amend it, make it a bit tighter. I did hypo again in my second week, but this time it wasn't kind of during the daytime. It was just kind of before my day. So I had to break my fast again. Again, didn't kind of risk carrying on. But as you can see, I kind of got better at fixing that kind of nighttime rise, and subsequently kind of fixing the rise during suhoor. As I carried on to week 3, it looks like we nailed it from feedback from doctors and all of that. So it looks like I've almost got, not only kind of perfect it kind of control, but also consistent. So as you can see, the variation is quite small. So it kind of showed whatever feedback we was getting, what we were trying, what's working. As always, someone who's never fasted, I got to kind of experience, the dragging on. I got to experience, the toughness of making decisions whilst you're kind of tired, and that kind of played on to how you manage your condition as well. So it was kind of a twofold experience. Dragging towards the end of it, it did get really, really tough. I think the enthusiasm was kind of running out by that time, and you're kind of like, I really did get to appreciate the challenges people face across the world. And I think that was really enlightening, because obviously as a diabetic, whenever you're hungry, you can just eat. It's not an issue. But again, kind of fasting and having kind of that responsibility kind of made you think a bit more and plan your meals a bit better. So that was a really, really big learning experience. Towards the 4th week, although I nailed kind of I had a few issues with my glucose control. I think that was cannula issues. So those are things to kind of watch out for. I did nail kind of the breaking of the fast kind of bolus, which looks really cool. But I struggled with the rise after suhoor, and obviously eating Asian food, fatty and protein kind of food with protein, they're kind of very hard to bolus for. And as you can see, even though I tried to be extremely tight, I had to be careful because while sleeping, my sugars would kind of rise. So that was a really interesting experience, and I learned a hell of a lot from it. I was very grateful for having the opportunity to do that. This year, I'm going to be a bit more careful. I'm going to try and do some fasting on the weekends before, kind of nail down my basals, think about hydration, Also be a bit more critical about the food I choose to eat. Although, you know, Asian food's lovely, it tastes super. I'm going to have to be careful to think about how that's going to affect my concentration in my day and how that's going to affect kind of the variation in my blood glucose. So that's the 30-day overview. It's amazing. I've learned so much about my body, and you can kind of see that it is a thing that's possible to do. There are challenges. There are risks, like big risks. And I only took part because it was a voluntary trial and it was led by, you know, consultant who's got humongous amount of experience and getting constant feedback. And again, the underlining thing was whenever I was unwell or my sugar dropped, I had to break my fast, and that wasn't an option. So just to conclude, as I said, fasting isn't easy. If you're going to attempt it safely, always go. Again, if you have a hypo or you're going to have one and you know it's not going to go well, stop, don't try and be brave and carry on. Loads of health benefits, and it's spiritually uplifting, and it really made me understand and appreciate the challenges that occur around the world. There's going to be loads of basal adjustments, and watch out for Asian food if you're Asian. That has a lot of fat and protein, so you're going to have to adjust. And using this data, hopefully they can kind of extrapolate it to other kind of situations, like in starving states with type 1. So I hope they use the data to make care better. And just remember, you'll have to make mistakes to learn. So that was kind of as much as I want to say. Thank you so much.
Mohammed, thank you very much for that patient perspective. Maybe just in the interest of time, just one or two quick points that you could answer. You know, for the broken fast, what was your approach? Did you pay into a specific charity, or did you redo the fast at a later date, or what was your approach to that?
So kind of my understanding of, obviously it's not compulsory for me to fast. Therefore, it kind of wasn't an obligation to carry on.
Yeah.
To kind of account for it. But I because it wasn't, it's not an obligation to fast because of the condition I have. It's not something I have to make up for.
Yeah.
Again, different people have different interpretations of it.
Yeah. But I think that would be really good advice for people in similar circumstances to yourself. You mentioned the Asian diet's been high in fat and protein. What about the carbohydrate content? Do you not think that's a very specific issue when it comes to managing your diabetes, particularly during Ramadan?
So yeah, that is a big issue, and I think we have to think about it in context. Sorry, I don't think I explained it too well. So with the system I use, the Android APS system, it is very, very good at accounting for carbohydrates. But when you do combine carbohydrates with fat and protein, that's something you kind of have to preempt for. And if you do get kind of your calculations a bit wrong, it does kind of go off. So yes, obviously carbohydrates, because they kind of get absorbed quite quick and they spike your sugars quite quick, it does pose a problem. But when you can kind of combine it with like the fatty foods and protein, you have that prolonged rise later on, a few hours later. So as a type 1 diabetic within this circumstance, you kind of have to preempt and plan for that. And that was something that was challenging, obviously, because it's something I've never done before. So I'm going to be a bit more proactive this year to kind of nail that.
Thank you very much, Mohammed. And I wish you all the best for Ramadan and eventual Eid Mubarak. So thank you very much, Mohammed. Much appreciated. Thank you. So we'll now move on to Dr. Mohammed Ali Karamat, who will present his talk on technology in Ramadan. I've known Ali for many years now. He has a very special interest in antenatal diabetes care, but also technologies, especially for the management of patients with type 1 diabetes. His various accolades include him being the program director now for diabetes and endocrinology for NHS health education in the West Midlands. He's been with us in the South Asian Health Foundation for many years now, and we always look forward to his presentations, which are full of practical advice. But being one of our younger members of our diabetes group, he is all things technology as well. And I'm really looking forward to your talk, Ali. So over to you.
Thank you very much, Vinod. So the outline of my talk is going to talk about a little bit briefly with regards to risk stratification. I know this has been covered in the earlier talk, so I'll be brief about that. We'll talk a little bit about the evidence base. And I think in terms of the evidence base for the use of technology, I'll talk about insulin pumps, as well as flash glucose monitoring, Libra. We'll talk a little bit about youngsters and adolescent age group and in teenagers, and fasting as well. And then I think really important that we got Irfan here, Muhammad Irfan Ismail, who talked about the use of technology in terms of how he fasted. And I think that was brilliant. So I'll talk a little bit about various devices which kind of can be used now, including the do-it-yourself looping, as well as the devices such as the hybrid closed loop, which have kind of really transformed the diabetes technology world in management of type 1. And then finally, I'll talk a little bit about the role of AI or artificial intelligence. So if I talk just in terms of the risk factors, I think we've talked a little bit about the very high risk in terms of those with admissions to hospital or those with hypo unawareness. And then if we look at the risk scoring now, straight away, if you've got somebody on an insulin pump, they do go into a high risk score. And also those who are hypo unaware or have developed recently severe hypoglycemia or multiple episodes of hypos, they also fall into the category of hypoglycemia. So that's the first thing to say. The advice in these categories is that they fall in the high risk group. And as Irfan alluded to, the understanding that he had was fantastic, because actually, if you are medically not able to fast, then you are exempt from fasting. And that's important to make sure. Now, what about type 1s who don't recognize when they're hypoglycemic? I think this would be a category which would be really important to advise not to fast, because actually these people would not recognize when they're going low, and that can cause actually problems with regards to hypoglycemia awareness and severe episodes of hypos. If we look at adolescents, again, sometimes the advice has been that they shouldn't fast, but actually what we are seeing now is that they can fast safely if they fulfill the criteria of good awareness. They've had some pre-Ramadan education, they can monitor their glucose levels. And I think in the earlier session, I advised that you perhaps need to reduce the longer acting insulin by anywhere from 30 to 40% as a starting point, and then adjust accordingly. And then the short acting insulin, we advise normally to take the same dose or maybe a higher dose at iftar. And I'll talk a little bit more about that when I go through some of the cases, and actually reduce the suhoor dose a little bit so you don't get lingering effects of hypoglycemia. A lot of it will depend on how the timing of the insulin works with food as well. And I think that's an important point to remember as well, how you're timing the insulin with food. So I'll talk a little bit about pumps now. So in terms of insulin pumps, we have type 1s mainly in the UK on pumps, but obviously in some other countries, you'll also have type 2s who with poor control might be on a pump. And in terms of the use of insulin pump, we reduce the basal rate and advise them to reduce it in at least the sort of 3 to 4 hours towards the end of the fast, but they may need to look at how their glucose levels are dropping. And then again, by looking at increasing it perhaps early after iftar, and then adopt the usual principles of carbohydrate counting as well as adjustments of the insulin sensitivity factors. In type 2, there is limited data, but there is definitely more data available in type 1. So the first study I'll talk about is intermittent fasting could be safely achieved in people with type 1 using structured education. And this was from Ali Al-Dibiat's group, who worked in the UK before moving over, and this was conducted actually in Kuwait. And what they looked at was a group of type 1s. They were either on a sensor augmented pump or on MDI and flash glucose monitoring in the categories. The ones on the pump had slightly better control with an HbA1c of 7.2% as marked here. And when you looked at how many days people were able to fast, those with the best control were able to fast between 20 to 29 days. Those with kind of intermediate control were able to fast 10 to 19, and with the highest A1Cs, they were able to fast less than 10 days. So it does depend on how your control is in terms of how much duration you're able to fast. And this is despite being given very good structured education advice based on the Daphne principles. If you look at the main evidence in terms of glucose, it's a busy slide, but the main thing is the one I've marked there, which is the statistically significant portion, which is talking about the episode or the percentage of time spent in hypoglycemia. And what actually you can see quite remarkably here is that before Ramadan compared to during Ramadan, actually there was a significant improvement and less time was spent in hypoglycemia, both under 3 millimoles per liter and actually under 4 millimoles per liter in both categories, whether they were on whether they were actually on a pump plus CGM like a sensor augmented pump, or they were on MDI plus a combination of flash. In both aspects, they actually had better sort of evidence of spending less time in a hypoglycemia range, which is really quite remarkable. This is just a graphic illustration of some of the aspects. So if I talk through some of these graphs, on the left-hand side, you've got the two figures which talk about before, during, and after Ramadan, and the time spent above 10, between 4 to 10, or under 4 millimoles per liter. And if you look at the time spent over 10 millimoles per liter, actually, you can see quite clearly that there was a slightly increased amount of time spent during Ramadan above 10 millimoles per liter. Between 4 and 10 was quite similar, and less time was spent in under 4 in the during Ramadan group. And this is illustrated in the other two graphs in terms of rate of hypoglycemia, firstly, being lower in Ramadan, and the glucose variability profiles in the middle graph actually quite nicely showing that before Ramadan compared to during Ramadan was better, and then after Ramadan was actually, it was maintained. The final sort of the final figure, which is the figure 4 here, demonstrates actually during the fasting time, what was the difference between the eating hours and the fasting hours. And there was a significant time which was spent above 10 millimoles per liter during the eating period, as opposed to the fasting period, which I suppose is expected, as demonstrated earlier with the foods that people are having. The next sort of couple of studies I'm going to talk about are the glucose monitoring technology studies. So one study looked at the incidence of hyper and hypoglycemia for fasting in people who did not have very good control in type 1, and these sort of were put on CGM. And what they were able to show here was that actually about 42% of the time they spent in range, 48% above range, but they also had 10% hypoglycemia. So with uncontrolled type 1, there was a higher episode evidence of hypoglycemia as well as hyperglycemia during fasting in these groups of 22 patients who did fast, but with not very good control to start with. If you look at the next study, that was about an initial increase in glucose variability during Ramadan. So this is a little bit more talking about flash glucose monitoring in children and adolescents with type 1. So we've had a few questions about the children and adolescents who are keen on fasting during Ramadan. And this study covered that and so looked at the use of flash. The below sort of is some description of different hypersymptoms which people had. And it varied from tiredness to being uncomfortable to sweating and dizziness. And people were able to report these symptoms while they were wearing flash glucose monitoring. The main sort of thing that we were able to show here again was that in terms of the two categories, those who were on pump versus those who were on multiple daily dose injections, actually those on pump had lower evidence of hypoglycemia, which was statistically significant compared to those who were on MDI therapy. And again, in the bottom, we are demonstrating the same, that during the fasting hours, the hypoglycemia was clearly lower in the pump category compared to the MDI category, and they were safer in terms of being able to maintain a fast with less hypoglycemic episodes during fasting hours compared to non-fasting hours. The next study is talking about glucose variability, and this is actually looking at people with type 2 diabetes. And this looked at different study visits. It's talked about visit 1 from before Ramadan, visit 2 in the early 3rd to 4th day of Ramadan, visit 3 towards the end of Ramadan, and then after Eid. And they looked at CGM, body measurements, blood tests, as well as a record of medications that these people were on. So what was the results that we saw in these studies? We actually saw that the mean amplitude of glucose excursions was actually higher in the fasting compared to the non-fasting group. Again, you could expect that with the variability and with the sort of different patterns in terms of eating. And actually, you saw it more if they were on more than 2 anti-diabetic agents, and particularly if they were on sulfonylurea, which were 13 patients in this study. But you actually could see much more amplitude of glucose excursions if they were on more than 2 agents or if they were on sulfonylureas. A lot of the other things in these categories actually remain similar, including time in range or hypo or hyperglycemia, and also the patient characteristics were fairly well matched with well-controlled people with sort of average HbA1c of around 6.7% at the beginning. The next study is actually a nice one, which talks about young patients with type 1, and this is a systematic review and meta-analysis. And this actually talks about different studies which looked at almost 1,700 people with fasting. Out of them, 200 people were on insulin pump therapy, and the remaining were on multiple daily dose injection therapy, and it looked at a variety of elements in this study. So what were the elements that this study talked about? The first thing they talked about was looking at the rate of hypoglycemia. And when they talked about hypoglycemia, what they actually were able to show was that non-severe hypoglycemia was slightly higher in this meta-analysis in the insulin pump group, but actually severe hypoglycemia was much lower in the insulin pump group compared to the MDI therapy group. So they actually were able to say that the severe hypoglycemia was significantly reduced, but non-severe hypoglycemia was a little bit higher in this meta-analysis of young patients who were on insulin pump therapy. The next bit they looked at was rate of hyperglycemia. And when they looked at the rates of hyperglycemia, they were actually 12% overall in the ones who were on the MDI therapy. And it was better actually in the pump ones, and the rates were lower at 9%. So hyperglycemia appeared to be a bit better in this meta-analysis in those who were on pump therapy versus those who were on multiple daily dose injections. It looked at rates of ketosis, and the rates of ketosis again were better in the pump group, with 2.5% in the non-pump or MDI therapy group and 1.6% in the ones which were on insulin pump therapy. So ketosis again being better in those who were on insulin pump therapy, which is, I suppose, slightly counter to what you would have thought with the mechanism of how insulin pumps work. Finally, if you looked at the pool proportion of breaking the fast, again higher in the group who were on multiple daily dose injections as compared to those who were on insulin pump therapy, suggesting that perhaps those who were on multiple daily dose injections had to break the fast more often than those who were on insulin pump therapy. And I think that probably explains a little bit because of the way pumps works and how they can mimic the body physiology a little bit more compared to multiple daily dose injections at times with the minute variations that you need to make. So overall, this meta-analysis suggested a better evidence of severe hypoglycemia, hyperglycemia, ketosis, and breaking the fast in pump patients versus non-pump patients. But non-severe hypoglycemia was actually higher in the insulin pump group compared to the MDI group. Overall, if you look at the groups, the two main differences were that the people who had been on pumps had longer duration of diabetes with slightly tighter control, which could explain some of the increased element of non-severe hypos in that group. So that's a little bit about the main sort of technologies that we currently use routinely, I suppose, with Libra, with some use of CGM, insulin pumps, and multiple daily dose injections. But we know the field of diabetes, and particularly type 1 diabetes, is advancing immensely. And we've now got use of things such as hybrid closed loops or DIY looping in Ramadan and in fasting, which can actually make a big difference. And Irfan alluded to how he does it. What I'm going to do is talk about a couple of cases in literature, which is quite sort of nicely demonstrate how people have done it. One is about a hybrid closed loop case, and one is about somebody who did DIY looping. And I will talk about the hybrid closed loop first. So this was a case from Qatar, 13-year-old boy who decided to fast during Ramadan. He was on a Minimed 670G hybrid closed loop. So for those in the audience who've not heard of that, this is essentially a system where you have an insulin pump device and you have a continuous glucose monitoring device, and the two communicate to each other. The CGM feeds into the pump around every 5 minutes or so. And it actually can make alterations to the basal insulin. So this was how they did it. This guy actually had quite high HbA1c prior to fasting, but since moving on to Minimed 670G, he achieved much better glycemic control with almost 76% time in range and A1Cs of around 6.7%, as opposed to Rebels, which were running between 8.8 and 11% before being on Minimed 670G. So this is what a Minimed 670G download looks like. So the A is during Ramadan and the B is the time before Ramadan. And both of those actually look fairly good. If you look at the national consensus for time in range, they recommend 70% time in range. So he actually maintained that in both aspects. The main way in which they achieved this was in the beginning, they tried to set up a temporary basal as soon as his glucose levels would go down to 4.4 and keep that going for at least 2 to 3 hours to avoid the risk of hypo. He did have to break a couple of fasts. And they also had to increase the insulin to carb ratio with iftar by about 20%. But just with those two changes, he was actually able to maintain fasts quite successfully for the rest of the Ramadan. But you could see the differences here during the 24-hour period. There was a clear difference in terms of the bolus insulin, with it being higher in the period of fasting actually compared to non-fasting. And again, that fits in with the feasting element of Ramadan that we often come across. And you can see quite clearly that there is a big difference in terms of the times of how much bolus he's actually requiring in the 2 time frames, which is the time of the fast between 4 and 6 o'clock, and the time in which he would be eating between 6 and 4 a.m. And you can see the bolus requirement is different with 5.3 versus 9.8. And if you look at the category, which is the overnight one, then obviously the bolus is much higher in the ones which is during Ramadan. And carb intake again is similarly reflecting, and the bolus insulin essentially reflecting the carb intake. So this is quite a nice example of somebody being able to fast successfully during Ramadan with a hybrid closed loop, and by making very minute changes of small basal rate and actually insulin carb ratio with iftar, and actually making quite nice changes and being able to fast successfully. The next is about a case of a girl who was who did with the looping with the do-it-yourself artificial pancreas system. So just to illustrate a little bit the difference, this is a brainchild of the We Are Not Waiting community, and essentially the looping with DIY is where you have an open source algorithm. So actually each person can individualize it by breaking into the code and actually using that. You could technically say that in terms of our legal and medical obligations with the GMC, as professionals, we would not necessarily be covered for that, but we have got a lot of people now who do looping with do it yourself and actually achieve fantastic results and control. So this girl is 24 years old. She's actually from the States. She's got, her husband is also a type 1, and a young girl as well, about 2 years old, who's also type 1. So you can imagine the family and the challenges. And the first time she decided to fast was when she used this loop system. So the first week of Ramadan, she had an average glucose of around 123 milligrams per deciliter. And what you could see was that she was actually having a few hypos overnight, and also a few hypos towards the evening. So what she did in the beginning, in the first week of Ramadan, was she put down actually an override on the looping and actually reduced her basal rate around the suhoor and early Ramadan time by about 30%, and then put an override of an increase of 40% after iftar. And I think that was probably a bit too much, because she ended up having a few hypos overnight and also afterwards. So she made some changes and she tweaked that, and she actually took the override away and just changed the ratio. And you can see how nicely during the next week she was able to maintain a glucose level, very mild hypoglycemia at night, but actually overall averaging 115 milligrams per deciliter with 91% in range. And evening was much better managed with, she did have to bolus about 30 minutes before iftar to actually cover for the rise that you get post iftar with the foods that we alluded to earlier, but it still maintained its level really nicely. And then towards the end of Ramadan, I think she did have a few mild issues with overnight problems, but she'd actually pretty much nailed it by that time with very little hypos. She was able to maintain excellent control. And at the end of Ramadan, I think her HbA1c was like 5.6%. And again, the major changes she made was slight changes to the basal rate. And the major change was after iftar, actually upping the ratio and adding another 20-30% onto the ratio, which goes a little bit against some of the guidelines which we say, which talks about ranging the basal rate changes anywhere between 5 and 50%. The final bit is quite a interesting study which talks about artificial intelligence based machine learning, and it talks about 5 different machine predicting algorithm. This is from, again, Qatar and Rayaz Malik's group, and this talked about an XG boost model, which basically talked about predicting glucose levels using things like pedometers, Fitbits, and free flash glucose monitoring in Libra. And it was able to predict hyperglycemia and glucose variability very nicely, but wasn't very good at predicting hypoglycemia. So to finalize, technology is advancing and it is likely to have a positive impact on fasting diabetes management during Ramadan. The use of DIY and hybrid closed looping is going to remain with us and is going to get more common. The use of glucose monitoring technologies and pumps is already advancing the management, and we might even see emerging evidence of the use of artificial intelligence in modeling how diabetes management plays on long term during Ramadan. Thank you very much for the opportunity.
Ali, thank you very much for an amazing talk. You've really taken us through the future for the next 5 years or so, really. I was really quite astonished by what innovative practice not your patients, just your patients, but many patients are making in relation to looking after themselves, especially in relation to the closed loop systems. And I wonder whether the future is very much remotely monitoring our patients during Ramadan. Very specifically, so just a Ramadan clinic that maybe a clinician would look after, say, 50 to 100 patients to make sure that they are fasting safely. Maybe we could take that up in the panel. So Ali, thank you very much. In the interest of time, we'll move on, and I'm sure we'll be able to discuss the finer aspects of what you talked about in the panel discussion. So our next speaker is Professor Azza Faruqi from Leicester. I've known him for many years now, and he's been working tirelessly in the east part of Leicester as a senior general practitioner and lead for his practice. After working for 20 years in that practice and that area, he was awarded the OBE for his services to medicine and health services. And East Leicester is a particularly deprived area of UK, and especially within Leicester itself. And he's done so extremely well with his ideas on how to manage patients with diabetes. Today, he'll be covering managing diabetes in older people, especially during Ramadan, and he'll be covering chronic kidney disease, cardiovascular disease, and other age considerations. So, Azza, thank you very much, and over to you.
Thank you. Thank you very much, Vinod. Thank you very much. When you speak at the end of the day, you find that much of the material you're covering has already been done, and I anticipated that. So I'm going to share quite a lot of pictures with you today. So chair and audience, hope you indulge me in that. Before I kick off talking about this subject, just acknowledgement of my data sources. Two really fantastic documents I would commend to you. First is the DAR IDF guidelines on Ramadan and fasting. Mohammed Hussainin is the editor of that. Fantastic document. It's been updated recently, and it's got hundreds of references. So certainly that's one I would recommend. And then, of course, our own SAHF guidelines, which have been updated also. Our chair, Vinod, Wasim, and others have been involved in developing that. So those are the two documents I would commend to you, and my source materials by and large. Okay, diabetes and older people. I think we all know that the elderly are more likely to have diabetes, particularly type 2 diabetes, and among South Asians, 30% or more of over 65s have diabetes. So therefore, when you come to the issue of discussing Ramadan fasting, this group is a really important one. Furthermore, most of these patients will have had diabetes for a long time, and therefore will often have complications of diabetes, which is an important consideration. Most, if not all, will have multimorbidity and polypharmacy, especially with respect to cardiovascular disease. And the studies I've looked at that show that up to 80% of these patients will be on 5 or more medications. And of course, fasting during Ramadan may pose specific challenges and risks. However, it's important to note that with the right support and advice, many of these patients can still fast safely. This slide here just shows you the prevalence of some diabetic complications or cardiovascular complications as well in these patients. The vast majority of them will have hypertension. The figure here is 66% for over 65s. And I think earlier on in the seminar, we've heard that probably 80% of diabetics are hypertensive. So that's probably an understatement. Many will have hyperlipidemia, and of course, other complications such as retinopathy and neuropathy, as well as history of cardiovascular disease, strokes, and so forth. And this slide, of course, does not include other multimorbidity, such as depression, which is very common, musculoskeletal problems, and respiratory problems. So it's no wonder these patients are on multiple drugs And while the diabetes clearly is an issue in terms of fasting, those conditions may also be relevant. And of course, age isn't always a negative factor. This is a mosque, the Shah Jahan Mosque in Woking in this country. It was the first mosque built in the UK, dates from 1889, and has now been through 2 world wars and 2 pandemics, still standing and still looking fresh there. It's modeled on the architecture style of North India. So just keep a note of the dome and the minarets, because I'm going to show you some more pictures later on. And this mosque was visited by many of the employees of Queen Victoria, including the famous Abdul, the Abdul and Victoria of the film you may have seen. He was a personal assistant to Queen Victoria. So the first question we ought to ask is, should older people, and I'm talking about 65 and over here, with diabetes fast? And this information I think we've been given multiple times today, but no harm reiterating it. Muslims who are ill are exempted from fasting. So that's something that is well accepted. People with diabetes at risk from complications are included within that category. So people who have diabetes and multiple complications or at a high risk are technically exempted from fasting. There are risks and benefits from fasting, and these are all very individual. So I'm going to stress a number of points in my talk today that we need individual assessment of patients. And the risks for older people include hyper and particularly hypoglycemia, falls, dehydration, and complications such as acute kidney injury. Benefits, which we don't stress often enough sometimes, include potentially weight loss. Some people during Ramadan do lose weight, and that's a positive thing for many. The opportunity to address other negative health habits such as smoking cessation, the opportunity to look at medication adherence, particularly with the 2 times a day that people can potentially take medicines, the psychological benefits of fasting. And I think in the older group, they are probably even stronger than in younger patients, because that feeling of community cohesion and of sort of developing your faith does have very profound psychological benefits for many people. So we have to balance the risks and the benefits when we advise people whether they really ought to be fasting or not. So do older people want to fast, and do they actually fast during Ramadan? I'm sorry, this slide is a bit small, but in terms of what I want to highlight to you is that yes, older people do want to fast, and the intention to fast, this study has shown that 71% of older people do wish to fast during Ramadan. And that is lower than younger people, but that may be related to the multimorbidity. But the interesting thing is that, in fact, actually completing fasting during the whole duration of Ramadan, older people manage it better than younger people, 69% compared to 61%. So there's something there about the resilience of older people. They're better than us youngsters quite often. So is fasting safe? So let's look at some data for over 65s. And I got this from the DAR 2020 survey. Hypoglycemia, we hear about that. That is certainly more common in the elderly, over 65s, with a prevalence of incidence of 17.4% versus 15.2%, so slightly higher. But hospitalization for hypoglycemia is much more, nearly 10% versus 4%. Older people are more likely to break the fast because of complications such as hypoglycemia. Hyperglycemia is also more common in the older groups, with about 8% of them being hospitalized. There is some evidence of greater risk of deterioration in renal function, particularly if they've got pre-existing CKD, but the evidence on a greater prevalence of stroke, CVA, heart failure, whilst fasting is mixed. And I think it depends on the population group, subgroups you are looking at, and the range of studies that are available give very, very mixed pictures. However, what is clear that individuals with diabetes that have pre-existing macrovascular complications, such as existing or unstable cardiovascular disease, shouldn't fast. And I think what this data really points to is the real importance of individual assessment and advice for patients. This, I think you will have seen earlier today. This is a risk assessment for diabetics who wish to fast. And as you can see in this, age is not a factor per se. It's really all the other potential complications of diabetes. So if you just recall that a score of over 3 puts you at moderate risk and over 6 puts you at high risk during Ramadan. And if you look at some of the scores here, hypoglycemia is a big factor. So if you have hypoglycemia and unawareness, you've got a risk score of 6.5 immediately. And certainly if you get recurrent hypoglycemia, also there's a high risk. Also, if you're on bolus insulin treatment, that gives you a score of 2.5. If you have a history of DKA in the previous 3 months, that gives you a score of 3 already. Cardiovascular disease, we've already talked about. So existing microvascular complications, particularly if they're unstable, give you a very high score. Renal complications with a eGFR less than 30 gives you a very high risk score. And specifically for the elderly issues, if you have impaired cognitive function, or if you are frail or elderly at home without support, that also gives you a high score of 3.5 or 6.5. And intense physical labor is the other point here, which is very highly scored. I don't think many elderly people may be necessarily doing that. So as you can see, a lot of those issues that I've raised, they're probably more common in older groups. So older people will inevitably score high on some of these risk scores, but it's very, very individual. And age per se, providing you don't have high scores in this table, don't preclude you from fasting. So the scores from that table are either 0 to 3, which is low risk, and low risk means that if you want to, you can fast. Moderate risk is 3.5 to 6, which means you're advised not to fast. In other words, you've got medical permission not to fast if you don't want to. And a high risk score, obviously you should not fast. And certainly for people with moderate and high risk scores here, they do need very bespoke advice around managing their diabetes during Ramadan if they choose to fast. So talking of high risk, this is the most northerly mosque in the world, the Nerd Camel Mosque in Siberia, the land of the midnight sun, where in summer daytime lasts weeks, I think. Now, how they manage to observe Ramadan, I don't know. I'm sure somebody will tell me they've got a special fatwa around their hours of fasting, but I'm sure it's quite a challenge. So in terms of managing risk in the elderly, individual assessment and advice is key. You need to have planned and structured assessment and advice, and structured education programs to help achieve this really do work. And we've got lots of evidence for that all around the world. There's a couple of references there. We also have evidence in the UK. So for example, the program that we've got around Safer Ramadan in Leicester, we've also evaluated and it's successful. In terms of patient education, NICE also has given us some advice around what good patient education should look like. And this also has lessons for Ramadan education. So again, NICE says patients with diabetes should be offered structured education. And I think patients who want to observe fasting during Ramadan, particularly the elderly, should be offered structured education and advice. Programs should be evidence-based, and we've got a number now that are. They should have aims and objectives, a curriculum delivered by trained educators and clinicians as appropriate. They should be quality assured and audited. And this I've taken from the DAR IDF document. It really is, describes a gold standard program, I think. It's around making sure that individuals are assessed well before Ramadan, maybe 6 to 8 weeks before Ramadan. And the structured education includes assessing their risk, as I've described already, the role of blood glucose monitoring, rules on when to break the fast, when to exercise, around fluid and meal planning, and around medication adjustments during fasting. So all those are key in any education that you do with patients. And clearly that's going to involve a detailed medical history. So clearly if your general practice is doing it, that's ideal because they'll have your full medical history already. And you need to look at the aspects of diabetes, comorbidities, individuals' prior experience of Ramadan, I think also is important, and the individual's ability to self-manage their diabetes and understand the risks of fasting. So all those are really important. And clearly at the end of that process, you will automatically have defined low, moderate and high risk patients. And of course, that is a very beautiful program, very structured and organized in the way it's delivered. And this is a very beautiful mosque, which I have had the pleasure of visiting, the Sheikh Zayed Mosque in Abu Dhabi. Fantastic place. If you get a chance, please do go and see it. So while a systematic program is recommended, we all know that much of the advice we give to people is ad hoc, and there's nothing wrong with that. Even as part of your ad hoc consultation with patients, you might see them before or during Ramadan or other times of the year. It is important to try and cover the risks of fasting if you get an opportunity to do so. Again, understanding the risks, including religious obligation, because we have heard previously that if you do have diabetes, which is tricky, there's no obligation for you to fast. And again, meal planning, exercise, blood glucose monitoring, medication advice, hypoglycemia, those are all the things you can cover in ad hoc appointments as well. And ad hoc can be okay. This mosque here is the Mari Mosque in Australia, built in 1861. And as you can see, it's got a roof, it's got walls, it's got good ventilation. It does what it needs to do. So structured programs are great, but don't forget, any intervention with patients can be beneficial. But beautiful things are better, obviously, than less beautiful things. And this is the Wazir Khan Mosque in Lahore. Another one I've had the pleasure of visiting. And Lahore is in the north of the Indian subcontinent. And if you look at the dome and the minarets here, they are very similar to the mosque in Woking that I showed you earlier. And this mosque also was built in the era of Shah Jahan, the Mughal emperor. So I'll talk a little bit about the Safer Ramadan project we've got in Leicester. This is composed of 3 elements, which I think are all important when we're working with patients and patient groups. So we've got patient self-management, we've got community awareness, and we've got health professional training. All those things are necessary to have a good education program for patients. Community awareness, really important. We need to work with communities because Ramadan is very much a community event. It's a family event. So the family do need to understand the impact of Ramadan on diabetes. So the people who cook in the family, who prepare the iftar meals, who sort out the functions in the day and the evening, really important. So we have a community awareness package as part of our program. Health professional training, really important. Many GPs, many nurses don't really understand the implications of Ramadan and fasting on diabetes. So therefore, we've got a health promotion, health professional training package as well, including case studies so people can understand what their role is in working with patients. And finally, we've got a patient self-management course as well, which is online and it's on video, and it can be an attended 2.5-hour program as well, which covers all the key choices in terms of how to deal with food, physical activity, and so on during Ramadan. And this mosque here is the Timbuktu mud-built mosque in Africa. This was built in 1327. And you may ask, how come a mud mosque is still standing 700 years later? And the answer is it's renewed every year. It gets a new layer of mud every year. And similarly with diabetes education, you need to renew it regularly. It's not a one-off thing. You need to renew it every year. The model may still be valid year after year, but it needs to be delivered and patients need to be re-educated. And indeed, health professionals need to, which is why we have this SAHF conference every year. So I'll quickly move on to medication. Now, clearly we've had multiple presentations today which have covered this. And the rules, I think, broadly apply to the elderly as well as they do to younger people. So most of the agents that we've got listed here are perfectly safe during Ramadan, providing that you discuss with the patient their dose, medication adherence, and have it as part of a comprehensive program. Special precautions with SGLT2s, I think, because there is a risk of dehydration during fasting, and you need to be aware of that, and possibly acute kidney injury in the elderly. So I would probably spend a bit more time with my patients around that particular medication. But all these medications can be used. They've got their pros and cons as listed and as discussed many times today. Sulfonylureas, however, I think are generally a bad idea in older patients, and certainly the same applies in during fasting. Glibenclamide has very poor data in terms of high risk of hypoglycemia. The more modern SUs are a bit better, but again, if they're going to be used, then you need to talk about the dose and modifying it during Ramadan. Insulin likewise has a higher risk of hypoglycemia. The more modern agents are probably superior, but again, you need to have very, very detailed, specific advice for patients, particularly elderly patients if they're on insulin and they really want to fast. By and large, you should try and persuade them not to fast if you can. So in terms of top tips, and this is taken from the DAR document, which lists some of the key things that you need to cover, particularly with the elderly. So it's around having an assessment and a medication review, making sure you adjust the medications in plenty of time for Ramadan. Make sure you cover the issue of blood glucose monitoring, an important thing, particularly in relation to hypoglycemia. Talk about diet and how to eat healthily during Ramadan, how to have meals which are nutritious but don't have huge boluses of carbohydrate, advice around physical activity, advice around social consideration, community support, and being aware of the complications and awareness of when it's appropriate to break the fast. So, in summary, older people with diabetes need special care if they are to fast. Most want to and can, in fact, fast safely. A personalized risk assessment is really vital. COVID, we haven't talked much about COVID, but COVID vaccination is okay while you're fasting. We now have had religious edict on this, including in local Leicester mosques and national mosques. So patients can have either first or second jabs. And Ramadan is an opportunity for review, reflection, and improvement. And I'm talking here about diabetes care. So really, it's a great opportunity for us healthcare professionals to do that jointly with our patients so their diabetes care improves during Ramadan and beyond. And we should aim high. This mosque here is the King Hassan Mosque in Morocco, 656 feet high. And those are the heights we should aim for in terms of the quality of our diabetes care as well. Thank you very much for listening. Thank you for indulging me, Vinod.
Azhar, thank you very much for an amazing talk. Lots of practical considerations, and you also made the whole audience think about all the holidays they were missing. So you took us through Lahore, Siberia, Australia, and even Leicester. So thank you very much for that overview. And we'll be picking up some of those ideas and themes in our discussion. So if I could have all the panelists members, so all the speakers who have spoken in the afternoon session, and Vaseem Hanif as well, if you would like to maybe join us as well. And I think Mohammed Hasnain may not be available. So if we could all assemble, as it were. Okay, so right. And Ali, if you could just put your camera on as well. I'm sure you've and Mohammed Ishmael as well as our patient perspective. If you've got your video camera, if you could put that on as well. Okay, so he may be joining us in a moment. So we actually have well over 60 questions, but I don't think we're going to get time for all of them. And I'll just start off with one that's general. I'll address it to Sarah, Dr. Sarah Ali. And we have a really interesting question from Hala Imajnu, who's stating that because of Ramadan last year took place during lockdown and reduced social activity, do you think that led to any specific changes in relationship to the stress of observing Ramadan? So do you think that had any evidence of any improvements in care or any specific deteriorations? I know that Professor Taz Chowdhury's work showed no clear evidence of increased hospital admission. So maybe, Sarah, you could answer that first, and I'll move on to other people.
So are we talking about medical problems in particular? So from a medical point of view, as Tahseen Chowdhury's study showed, there wasn't an increase in admissions.
I mean, because people didn't have to go to work, for example, did that mean that the Ramadan, how was it different?
I think one of the things that our study highlights, which was that we got about 550 participants to discuss their experiences of COVID and Ramadan, and I think one of the things they found was, which was we had predicted, was that it was much more isolating than normal. So where people were normally in Ramadan will meet for meals with family and friends, will go to the mosque and will do prayers together, they found that was much more challenging. Mm-hmm. There was this new innovation that happened during COVID last year, Ramadan last year, which was virtual prayers, and quite a lot of people interacted with that and found that really quite useful. And we're hoping to publish our data from our study survey soon, but they found that the virtual prayers were really a good way to interact with people. There was innovative ideas about breaking fast together virtually, but I think that you cannot deny that there was an impact on in terms of feeling isolated. But from our survey, we didn't find any change in mental well-being.
Thank you, Sarah. Is there
add to that, Vinod?
Yes, Azhar, come in, please come in.
Yeah. I mean, I would agree with Sarah in terms of the mental and psychological impacts. But one thing for certain we know happened is that there were much less reviews of diabetes in primary care and probably in hospital as well. And that would, of course, include all the pre-Ramadan and Ramadan advice we gave to people. And I think the upshot of that, we may or may not have data on whether that impacted on hypoglycemia or admissions. But what I think it has contributed to is poorer control of diabetes. And now in general practice, we are seeing many patients whose control over the last year has deteriorated. And many of them haven't had blood tests on time or haven't had their annual reviews. And I think that is a big problem. It's going to be a big problem for us in the next year or two in terms of diabetes complications, as well as a big backlog of work that we've got to do.
Thank you, Azhar. Mohammed Ismail, do you have a perspective on that from the point of view of being a patient or person with diabetes, I should say?
Yeah, I'm quite kind of active in the diabetes community. I've got a lot of diabetic friends. A lot of people have said it's been really, really difficult. Obviously, clinicians have tried their best to do virtual appointments, and you miss that human interaction. A lot of people have struggled to get through to for advice, and it is tough, I guess. Mentally, I think it's going to affect them more, and obviously that's going to have a physical impact. As a patient, I think we have to adapt. Well, healthcare will have to adapt, and I'm just interested to see how things will change. But on the flip side, the advantages is there are some patients that do like the virtual appointments. I myself, not having to travel for so long, you can kind of ping results over and get feedback very quickly. So there are some pros to it.
Yeah, so I think maybe the future is a hybrid approach where we do use video technology, telephone technology to have certain consultations, others would be in person. So I'll move on to another question now. So this is from Sudhir, and he's basically saying, it's interesting to see that fasting in certain northern countries, like the European ones and the Russian ones that Azhar alluded to, can be very long or very short indeed. and are any modifications allowed? So maybe Mohammed could give me an answer to that first, and then Wasim. Mohammed Hassanein, are you there?
No, Mohammed is not here. I'll take that.
Wasim, yeah. If you go first, and then we can ask.
Yeah, so I think so. There is a very clear edict of fatwa as to because this is answering Azhar's question as well, as to at what point you know, when the fasting is for 24 hours in Siberia. Most kind of authorities agreed once it crosses about 21 hours, that is when they start following either the timings in Mecca or to the closest to what you would call a Muslim country, so which to UK is Morocco. So there are some people in the UK, in Scotland, who tend to follow that fatwa. So once it crosses a certain point, because if you're going to have daylight for 24 hours, it's not going to be practical for you to fast. So that is what is accepted by most religious authorities.
Okay, Mohammed Hassanein, I think, is there, but if not, can I ask Mohammed Al Hajj to maybe give me a viewpoint on that? I think you were about to say something.
Wasim said actually is very true. So just what he mentioned here.
Your voice is not very loud, Mohammed, please.
Yes.
I'll come closer to the.
Yeah.
Right. So what I would like to add to what Wasim mentioned, which is very true. So part of that fatwa is to follow the closest country. I mean, regardless whether this is like a Muslim or non-Muslim country, the fasting there is realistic. So, for example, I mean, if we take Finland there, Finland a few years ago, they had to fast for like 22 hours and breaking the fast only like less than a couple of hours practically. And that's not feasible at all. So they're being advised to follow the closest country, which hours of fasting can be feasible. And UK was an example for that one. So it doesn't have to be like Mecca all the time, I mean, to follow, but you follow the closest country where hours of fasting can be feasible and can be practical to do.
Thank you very much for that. So let's move on to another set of questions, really. So we've got a question here to all of the panelists, actually. So maybe, can Ramadan be modified in any way to use as a fasting model to help our patients towards remission or even prevention of diabetes? So can, for example, maybe you could start off with like a pre-Ramadan month, maybe a couple of months, and then Ramadan itself. So you've actually got the full 3 months of the low-calorie, almost fasting diet. Then obviously we're going to have problems with hydration during that time. So Ali, can I start off with you there? Well, I'll ask everybody for a quick comment on that one.
So I think the first thing, obviously, to make clear is that we're talking about remission in type 2 diabetes. There has also been a comment or a question about keto and diet and stuff in type 1. So that's a simple no. There is no sort of diet that would cause remission of type 1 diabetes. So that's just make that very, very clear straight away. With regards to type 2, yes, I think there is a role definitely of fasting beyond Ramadan as well, and the health benefits. And if you follow the Sunnah, for example, then there was actually Sunnah where the Prophet used to fast a couple of days a week, for example, which actually has very good long-lasting health effects. So absolutely, the long-lasting effects are there, and remission of type 2 with that is something which can be a really, really good outcome.
Yeah, thanks very much. Azhar, do you have a viewpoint on that at all?
I've never really thought about a low-calorie diet in Ramadan, but I guess we need to do some studies whether, in fact, fasting will help people go onto those. You know, it sort of facilitates moving to a low-calorie diet if you incorporate it as part of fasting. It's an interesting concept. Yeah,
and it could well be that Ramadan is actually the first month of that 3 months of fasting in a year.
That's an interesting idea. We should do a study.
Yeah, that's a great idea. Sarah, have you got any viewpoints on that?
Yeah, I think I would agree with what Ali and Azhar have said so far. I just wanted to actually give my own personal. I know it's anecdotal and it's only N of 1, but I actually 2 years ago did a very low calorie diet in Ramadan, and I started it, and it was the thing that I found really interesting is because my willpower is the strongest during Ramadan, that I found it really easy to sustain afterwards and keep it going. And I think it's great, and it had real health benefits to myself.
Thank you very much. Mohammed Al-Haj, yeah?
Yeah, Vinod. So 30 days of fasting, actually, and Ramadan itself.
Just a little louder, please. Just a little louder. Yeah.
So fasting in Ramadan, actually, and Ramadan itself, it's a nice school every year to change the bad habits and to correct the attitude of people. So spiritually and also on a health point of view as well. So I think, I mean, if they start in Ramadan with a good pre-assessment at the beginning, having a proper dietary plan for them during Ramadan, which is like a low-calorie diet, it will be a good starting point for these patients. And we all remember the data coming from direct study there, when losing certain amount of weight will be the way to remission of diabetes. So I would advise all those patients who are like on a diet and exercise at this stage to take Ramadan as a great opportunity, and also to add to that one, after Ramadan, a couple of days a week, where they have like a low calorie intake as well, and they maintain what they achieved during the month of Ramadan. It is quite important to take like the Sunnah days as well. And we have always Shawwal, where people advise by Sunnah to fast like 6 days of Shawwal, which is really great. So this after the month of Ramadan, so they can continue that good habit and they can persist the weight loss they achieved during the month of Ramadan.
Yeah. Okay. Thank you very much. Vaseem, do you have any points? Then we'll move on to.
Yeah, I think, we had thought about this a few years ago, about, I think 3 years ago. Kamlesh and I, along with Roy Taylor and Mike Lane from Direct Study, and this was Sam, I'm not sure they were involved in that, we put in an HTA grant for a study, what we call Disha. This was basically a direct study in a South Asian cohort with, I think Naveed was involved with an emphasis on Ramadan. And the whole point of the study was to get the patients when they were going to fast during Ramadan, so that it's going to be easy. And there was some data suggesting, as Sarah said, that the patients are well motivated. Unfortunately, we couldn't get the grant, but if there anybody listening from funding bodies and would be interested, please let them know.
Yeah, I think that
we'll be more than happy. We'll be more than happy to collaborate.
Thank you, Mohammed Ishmael. Any final points there?
No, I wouldn't want to comment on that.
Okay,
that's something I've no experience on, but yeah, thanks.
Okay, we'll leave you out of that. There's a question here, and I think it's a very important one, about how should we specifically advise our patients in relation to physical activity and hydration. When it comes to hydration, I specifically advise my patients to have foods that are packed with water that is slowly absorbed, such as cucumber and fruits and vegetables as well. So physical activity and how to avoid dehydration. So Azhar, I may as well start off with you. It'll be.
Yeah, I still advise them to drink 2 liters during the times that they can drink, so have good fluid intake. And again, I think your comments on water-rich foods is important. And clearly, my talk was on the elderly. In the summertime when it's really hot, you do have to advise them to keep out of and doing any strenuous activity in the sun, because they will become dehydrated. And again, you need to look at their medication. If they're on SGLT2s, special precautions, I would say.
Thank you very much. Sarah? Physical activity and maintaining hydration during Ramadan.
So I would agree with what you said about the water-rich foods, and what Azhar said about ensuring that people drink at least 2 liters of fluid. And I think it's really important just to emphasize also that because especially in Northern European countries, the fasts are so long that the time that's left over in non-fasting hours, there will be occupied with mainly sleeping and the prayers. So it's really important to ensure that they carry their water bottles if they're going for nightly prayers in the mosques, and drinking lots and lots of fluid.
Yeah, thank you. Has Mohammed or Ali got anything to add to that at all?
If I add something very quick, which is like a practical advice for people, especially on sahur meal, to avoid any salty ingredients there with that one, because that will make them feeling more thirsty during the day. And also to emphasize on what, as I said, which is like 2 to 3 liters. So I push always patients to take like 2 to 3 liters during the day, and also to avoid any intensive exercise during the day. So moderate exercise and walking is very much encouraged during the day. And this is always what we advise our patients to do. And we add to that one their activity as well, to prayers or going to the mosque in the non-fasting hours. So that altogether should keep the physical activity running during the month of Ramadan.
Thank you, thank you. Sarah, do you want to come in at that point? Yeah.
Could I just say something about physical activity? And this won't apply to everyone, because I think most people will know how especially young people, will know how they may exercise regularly anyway outside of Ramadan, and they know their bodies. And so, if they are going to exercise, then I would also suggest that they exercise near the end of the fast, where it's easy to then replete themselves. And that's what I do in Ramadan, is I do it right at the end.
Yeah. Okay. Mohammed, Ishmael, have you got any points to add in on about physical activity during Ramadan?
So from a personal perspective, as a type 1 diabetic, it was a risky thing to do last year, obviously, because I'd never experienced doing it. I did try it for a day or two. And obviously for type 1 and exercise, kind of aerobic and anaerobic have different effects on you. So I did try light exercise, but I was absolutely exhausted, I think, because it was my first time fasting. And then you're adding dehydration to that. So from a patient perspective, it was very difficult. Maybe I will plan it a bit better this year, but I don't know if I'm willing to risk it, just because it might break my fast.
Yeah, I can understand that. So one of the points that we have here, which is quite general, is can anybody request a pre-Ramadan assessment in primary care in UK or other countries, or can it only be for people with type 2 diabetes? So I think that's quite a general question. I don't know, maybe I could just ask one person to answer that, Azza.
Well, I think anybody can, type 1 or type 2, and probably should if they're intending to fast. The problem, Vinod, is really one, capacity. So if you're in a high Muslim area where maybe 50% of your population is, you're suddenly faced with thousands of appointments potentially in a short period of time. And the other issue is actually awareness and confidence amongst healthcare professionals as well, which is why we've got our training program, and I'm sure other areas have as well for healthcare professionals. So the short answer is yes, they should.
Yeah, thank you. Vaseem, you want to come in here?
Yeah, Vinod, you see, one of the challenges that we have caught in terms of pre-Ramadan counseling, so if I look at our patient cohort, about a third of them in Birmingham are from Muslim faith. And if I were to give an appointment, or if any of my primary care colleagues where the percentage is much higher, 2 months before Ramadan, for all of them to have the Ramadan review, it is almost practically not possible to do it. Now, we have looked at this very carefully, and at SAHF and at previous conferences. What we have suggested is to do what is known as a cultural competence consultation, which means that anybody who comes for a diabetes review, I think SAHF has developed 7 questions to ask them, and this includes, do you undertake religious fasting, what the fasting involves, and all that. And during the consultation, and this could be done at any of the visits, and if the patient mentions that they undertake religious fasting, then they should be given proper advice about what to do, what not to do, what their risk is. And so this could be a Ramadan counseling that happens at the consultation. The challenge with the pre-Ramadan counseling is, although we talk about it, we promote it, in a country like UK, it is very, very difficult pragmatically to implement it. So I think if Ramadan counseling or counseling for religious fasting, and as you know, Hindus tend to fast during Navratri and all that, if it is incorporated into a GP consultation, and this is where we are trying to push that, then it becomes much more easy in terms of adjusting medication, or even deciding
Yeah.
So if you've got somebody who's going to fast, is elderly, has got a risk, high risk, I wouldn't want to start them on a sulfonylurea, but want to prefer them on a DPP-4 and SGLT2. So these are the kind of decisions that can be made.
Yeah, I think that's a really good point, Vaseem. So what you're essentially advocating is that rather than being specific to Ramadan, a health system that is culturally competent will actually address these issues throughout the year and for individual circumstances.
That is what we should probably be pushing at, both at the policy level and things like that, and especially when we're talking about health inequalities and disproportionate outcomes. One of the issues is that the healthcare systems should be able to be able to cope with a multi-ethnic, diverse population, and this is something I'm very keen to take it forward as a kind of an implementation, because till now it has always been done in a bit of a silo by people who are a bit of interested. Unless and until the healthcare system gets interested, and this is for people like Azhar to push it, they have done some fantastic job in Leicester, for the healthcare systems to get interested and to acknowledge that religion and cultural social practices is going to have an effect on the outcomes. So I think whenever you talk about ethnicity, somehow we have got into this thing, it's all about language and interpreters. No, it is not. It is about getting these cultural practices integrated into our healthcare systems.
Thank you very much. There is, just getting back to the physical activity a little bit, there's a very interesting point here saying that maybe from Aisha Ali saying that maybe physical activity does not need to be increased or even necessary because the Tarawih prayers can be quite exhausting. So I'm just wondering whether I could have a couple of perspectives on that.
We actually put that in our SAHF guidelines, our diabetes and Ramadan guidelines, that the cycle of movements that you perform during Tarawih are quite strenuous, and so they should be considered as physical activity. So yes, that is a really good point.
That's a really good point. Thank you very much for that.
Can I just come back to Wasim's comments, which I think were very, very appropriate. Because one of the things we haven't got, we've got all these templates in primary care, system 1 templates and so on, and diabetes. To my recollection, none of them have any cultural competency questions on them. For example, fasting. Maybe that's something we should push for, because Wasim is quite right. You can't do all this work in a period of 6 weeks before Ramadan.
No.
Maybe you can do some of the community awareness programs, and maybe you can even put on professional training programs, but you can't do the patient interactions all in that short period. So it needs to be sort of mainstreamed really in a way as part of their usual care.
Yeah. Rather like how we ask patients, the women who have diabetes of childbearing age, if they're planning pregnancies, we should be doing it on a regular basis every time they come for a regular annual review.
Yeah, a really good point. And Sarah, Vaseem and myself, we're working on this, aren't we, in terms of how does ethnicity, race and religion affect diabetes care? We're doing a little bit of work on that at the moment. Mohammed Al-Haj, you've got a point to make?
No, I just want to add to what Sarah mentioned actually about the Tarawih. So again, I mean, this is like should be taken on an individual basis. And the reason for that one, I mean, if I pray Tarawih, for example, at home, doing 8 rakahs, that would be done in 30-40 minutes. If I go to the masjid, for example, and have a bit of walk, when I park my car and then walk and do Tarawih there behind an imam, praying like 20 rakahs, I'm going to spend there about 1.5 hours and then another like 10 minutes or 20 minutes walking. So it's really varies from case to case. It depends on what level of activity involved in that Tarawih prayers. So again, that should be always discussed in the pre-assessment. And we have to bear in mind as well, I mean, ladies in general, they don't tend to go to Tarawih prayers and they stay at home. So I think, I mean, that should be taken in consideration as well.
Yep. Thank you very much. I'm going to ask a comment and a question to Ali and Mohammed Ismail next, basically. Ali, you did a great talk on technologies and closed loop systems. Do you think we should be moving towards having specific clinics, as it were, for patients with diabetes, with the technologies undergoing Ramadan? So, for example, you'll be the sort of the super controller of a group of patients, maybe 30, maybe 40, maybe more, and reviewing them, because you actually know the time that the fasts are going to be broken and the timelines as well. Ali.
Yeah, I think that's a wonderful idea, and I think that would be really helpful. I think it's the numbers which we perhaps need to look at, because obviously there are not many people like Irfan who actually do sort of take this kind of impact and this sort of, if you look at the total numbers, for example, I mean, Irfan can correct me, but from my last sort of looks at it, there were a total of, I think, 300 people overall in the community of loopers in the UK. The numbers may have increased since then. So when you're looking at kind of the numbers, it might not be that big, but absolutely, I think that there is definitely a role to play here. What I would add here is that these are the people who, like Irfan, are very, very adept at self-management of their diabetes. And actually what they need is a lot less than some of the other type 1s who I would worry more about, who actually are perhaps on multiple daily dose injections, who actually perhaps need a lot more input in terms of how they would adjust their diabetes management than some of the more sort of ones who are on super technology, very adept at self-managing, very adept at looping and converting and controlling their diabetes. So I think there's just important to differentiate between that.
Yeah, sure. Ali, but although there are only 300 people on the loop hybrid systems in UK, I think flash monitoring will also lend itself to that anyway, won't it?
So yeah, I think there are people who are using a lot of different systems now, which are available, and a lot of people will be in the end using the flash as well as a form of looping as we progress. And there are already some people doing that. But what I'm just trying to suggest here is that yes, this is an important group, but we also need to remember the other group who are perhaps just on a flash, on multiple daily dose injections, and actually need perhaps a lot more input in terms of the education on self-management of their diabetes, while people like Irfan actually, with a bit of support from their consultants, have already kind of self-managed their diabetes really, really nicely and actually achieved already very, very good control. The examples I used in sort of one of the cases in particular, she actually did a lot of those changes herself, as Irfan did last year. A lot of these changes they made themselves. There is definitely a role of a clinic, and I think there's a role of a type 1 clinic per se for Ramadan, actually, so we can support people who want to fast during Ramadan. So there's no doubt about that. But whether you keep it a super tech clinic or you actually just keep it as a type 1 clinic is where kind of slightly we perhaps need to perhaps debate that a little bit more. And my sort of view would be that we perhaps need to incorporate a little bit more of the general type 1s in there, as well as those who are on super tech.
Okay, so moving towards the end, Mohammed, do you have anything to add there in terms of the technology and fasting and how it should be monitored by your healthcare professional, as it were?
So from my kind of perspective, my consultant's not from an ethnic minority, and I don't have, none of my diabetes nurses were. So even to get that sort of advice is very, very, very difficult. I was kind of fortunate I came last year, and I was lucky to be put into contact with people quite quick that were very helpful. I do think, though, looking at the near future, the amazing advancement in technology has given us the opportunity to try it out. And I think in the future, when these things become a lot more accurate and insulin's action time becomes a lot shorter, then I think it's a realistic kind of thing. So I think we're still in that transition period over the next kind of 5 to 10 years of how to manage and make that a reality. And I think that's an exciting discussion as a type 1 diabetic to see that. And so I think for you guys, it'll be brilliant, wouldn't it? Be able to mix all this up and work with patients to find kind of the best solutions to say this is possible. But the bottom line is it's not a compulsory thing yet, and there are massive risks. So we have to be managing that.
Right. Thank you very much. So we've just got 2 minutes left of the panel discussion. So what I'd like now is everybody on the panel just to give me one point that you want the participants, and we've got well over 200 already, even this late, listening in. So one practical tip for diabetes and Ramadan. Mohammed, I'll start with you, and then next will be Mohammed Al-Haj, and then Azhar, Sarah, Ali, and I'll finish off with Vaseem and Mohammed Hassainan. Okay, off you go, Mohammed. So one point that you want people to go away with from the conference for diabetes and Ramadan.
I think, I think we're blessed to be here with all these experts and all this information out there. Learn from it, use it, spread it. And I think the power of education now that's available and how many studies are available out there. I think we're like blessed to be in such an era. So thank you so much.
Thank you very much. Mohammed Al-Hajj?
Right, Vinod. So what I would say to people around, education, education, education. So think of like starting education on different levels, for primary care, for secondary care, and also public webinars, which will support patients and the environment around these patients. In Wales, we started this year a campaign called Healthy Ramadan Camry, and hopefully we're going to share with you the outcomes of that one using a radio, which is Radio Ramadan as well, delivering 8 to 10 sessions during Ramadan, in addition to different education sessions as well provided for healthcare professionals. Everyone on this webinar can think of like models around them and think of education. Thank you.
Thank you very much. I mean, Radio Ramadan sounds fantastic. And the last day of celebration as well with Eid, that'd be brilliant. Yeah. Azhar, your comment, please?
Yeah, just one point. My point would be, make sure all your diabetics have had the COVID vaccine.
Thank you very much. Yeah, quite clear. And I forgot to actually mention that Azhar has done sterling work on this. He's been on the BBC, he's been on all the newspapers, even
he's been on
my
the
newspaper
Times as well. Yeah,
he appears to be in them.
Difference.
Yeah, he's been where? Sorry, Vaseem?
He's been in the Times, Sunday Times as well, an article on Azhar.
Yeah, Sunday Times.
JCVI now.
Yeah, I didn't know you read that, Vaseem, but yes.
If was Kamlesh to Sage, we'll send Azhar to JCVI.
Yeah, thank you very much. Sarah, your comment?
Well, Azhar took mine. I was going to do the vaccination one. So I think it's just to reiterate to the people that want to fast that they should stay safe, not take any risks if they're unwell, not to fast, and that to remember that the Almighty God is most merciful and He will forgive you if you can't fast.
Thank you very much. Ali?
I think my point is going to be actually listening to the people living with diabetes. I think that's probably the major point I would like to make, because actually they are the experts of their diabetes. They live with their diabetes 365 days a year. As healthcare professionals, we are seeing them 2 or 3 times in the year. We can support them, but actually giving them the empowerment to self-manage their diabetes the best and listening to them and support them with that would be my major piece of advice for all healthcare professionals.
Thank you very much. And I think my point, if I'm allowed to do that, although I'm chairing the panel, would be that we should give our patients written advice on how the medications could be changed during Ramadan, to absolutely make it crystal clear as to how the doses of insulin can change, how the dosages of the drugs can change, and how quickly they can go back to what they were before. So Vaseem, at this stage, I'm very happy to hand over to you for your final comment and to close our 2 conferences as the chair of our diabetes group, together with Kamlesh and Mohammed Hassanain, who looks after the DAR group.
Thank you very much, Vinod, and thank you very much for sharing. So my last comment today would be, again, I have been talking about this, I'm really passionate. It's about cultural competence. It is about getting that cultural competence as a part of our routine healthcare, where we ask a patient that they're fasting or feasting or going on pilgrimages for whatever reasons, and then being able to give that advice. Because I think unless and until we ask our patients, we are not going to get those conversations going. So thank you very much. So it's my great pleasure, along with my co-chair, Mohammed Hassanain, who had to go because it's quite late and he's in Dubai, to close the conference. Now, you would all agree that this was an absolutely great conference, and I really, really enjoyed it, every minute of it. What is really important for people to know, that we had nearly 1,000 registered delegates. That's a big number. And most of the people actually attended the conference, which is absolutely fantastic. And these people have not only been from the UK, but across the globe. So a big thank you for the delegates who made it possible for it to be so good, and their interactions in terms of questions and chats has been absolutely brilliant. Now, whenever we do these conferences, and we do at least twice a year and do a lot of work from South Asian Health Foundation, we get a lot of good speakers, trustees, as we had today. But very few people know that the person who actually does most of this work and makes these conferences possible, gets all the delegates in and interacts with the sponsors, is our lovely general manager, Raj Gill, or I will give her full name, Rajvinder Gill. So this has not been possible without Raj's effort. So a very, very big thank you to Raj. And I want to thank her on behalf of the chair of the trustees, Kiran Patel, and all the trustees for the fantastic job she is doing with SAHF. And for any of the interactions that happen, you all deal with Raj. Normally, I would have given her a bouquet of flowers, but this is virtual, so go and buy for yourself, Raj. The second people, again, who have it's been possible with the fantastic IT support we had today for getting more than 1,000 delegates to actually log in without any technical hitch, has been our kind of IT event partners, which is Amber Events. So a very, very big thank you to Rafat and Amir, who have made it possible. So really thankful to you. Now, any of these symposiums or conferences are not really possible without getting support from the industry. As you all know, South Asian Health Foundation is a registered charity. So most of our funding comes from the industry in terms of holding this conference. So this year, we want to say a big thank you to AstraZeneca, who has been our gold sponsors, for helping us to give to get this conference. Along with it, we had other sponsors as well. So this is Eli Lilly, Sanofi, Abbott, Novo Nordisk, and Viatris. So a big thank you to them. And of course, I would like to take this opportunity to thank all the lovely speakers for both the sessions who have spent a lot of time and effort to join us with their excellent presentations. So that big thank you. Now, in terms of a few practical things, we have got a delegate feedback form, and we really, really value if you can please complete it, because that is very important and helps us to plan and design future conferences. Secondly, a lot of people have asked about the certificates, so we will be sending you the certificates. But if you do a delegate feedback form, it becomes easy for us to send you a proper certificate. Second is, a lot of people have asked about the recordings of this conference along with the presentations, whether they will be available. The answer is yes. Once the conference is available, our event partners, Amber, will edit a few things, and then it will be available. I think the links have already been sent in the chats, and we will also be emailing it to all the registered delegates as to how they can access the conference and share it with the colleagues who could not join the conference either partly or fully. I think that is pretty much about it, and I want to really thank my good friend and colleague Vinod Patel. He would probably be taking us out for a curry now, but now we just need to go and eat our own sandwiches, which are or whatever. But it's been great. So thank you very much. And with that, I will say stay safe. We are hoping, there's one more thing. So we're doing this session called Training the Trainers, which is a kind of an idea of DAR workshop to help people who want to get trained and spread the education. This is slated for the 9th of April at 2 p.m. UK time, so you can register and join. So that will discuss specific cases, which will be a kind of a practical guideline from today's conference. The second element is we have got the SAHF annual conference, which is slated for 15th of October. We are hoping and praying that in the UK we'll have a face-to-face, but we are going to, even if we haven't managed to get a face-to-face, it will be a hybrid conference. So please look out for the announcements, and it will be great to join. And the next year SAHF DAR conference will probably be about a month or 6 weeks before Ramadan, and that will be in London. So let's see whether it's going to be face-to-face, but I think what we have learned is that all the conferences now will be hybrid. So on that good note, stay safe. Wish you a very, very happy Ramadan. May this be a blessed Ramadan for you. and prays for the whole humanity that we come out of this pandemic. Thank you.
Thank you very much, Wasim. Thank you.